our winter plans at that point. So I suspect that when we get through the escalation report and the exec report, that we can get an update on how we fit, how those winter plans have appeared as we've got through. And so a big, huge welcome. We do have some apologies. Before I get into that, can I just remind anybody that's on screen in particular, I mean, a note to everybody that will be live streamed, but particularly for those on the screen, if you do need to take calls, please switch your camera off and do that to the side, because we are being live streamed and it's a bit distracting for people to be seeing that. And a reminder also, particularly for people in the room, that the sound can be quite quickly. So if you need to have conversations, just keep in mind that. We've got apologies from Rhiannon Beyond Wood, who's one of the non-executive members, Nick Island, who's the ICB board member for Dorset Council, and also his chief exec, Matt Prosser. Unfortunately, I think this would have been Matt Prosser's last meeting, so it's a shame that he's not here with us, but we will record our thanks to him at the end of the meeting and wish him all the best for his new endeavour. I'll say more about that when we get to the other business. And then we've also had apologies from Andrew Rosser. I want to welcome Paula. Paula, where are you? I think I passed you on the way out when I was rushing to the loo. So I want to welcome Paula Bennett, who's the Programme Director for the Dorset Voluntary and Community Sector Assembly. This is your first meeting, so a big welcome to you. Would you like to just say anything by way of introduction to your board members? You can meet them all properly later on, but if you'd like to say a bit of introduction.
Yeah, hello everybody. So the Voluntary Sector Assembly is an opportunity to improve the working relationships between statutory sector and voluntary sector, like commissioning, collaboration, communication, and also just general engagement, really. It's an opportunity to have a single point you can come to in order to be able to meet the people that you need to meet, offering the services that you need to know about. So please do come and make contact with us so that we can do that. The Assembly has been running now for a little while, but it's kind of a restart really with the employment of a new post. So I am more than happy to answer any questions people have got, put people in contact with who they might need to be put in contact with. So make use of us as we're here.
Thank you. And hello, also Charlie. So a reminder that this part of the meeting is in public. It's an opportunity for the public to see what we do, how we do our business, hear some of the issues that the ICB and the system are responding to. But it's in public, not a public meeting, which means the public don't get to ask us questions unless a question has been submitted in advance. And I can say for this meeting, we haven't had any questions submitted in advance. So that's probably all I wanted to say at this point. We will break for lunch at 1:30. So if we are running behind, I'm going to have to shoo people on to make sure that we finish at that time. Because you may recall when we met on the 7th of November, one of the things we did was to thank a couple of teams that had received awards. One was the Hydration Project Representation team, and then the other one was Check Before You Order, Structured Medications Review Representation. Paul gave us some information about those two teams winning awards, and we said it would be nice if we could invite them for a lunch with the board to also give our thanks. So that lunch is today. That is at 1:30. I don't want to keep people waiting, so we will be promptly at 1:30, and then they will join us here for lunch this afternoon. Just before we go into lunch, I'll say a bit more about those teams so that we just have that information. Okay, if people are ready to proceed then, can I check if there are any declarations of interest? Okay. So let's then go to the minutes of the last meeting. And I'm going to walk us through the 11 pages just to check whether or not there are, whether or not you think the minutes are accurate or not, or if there are any questions around what's been written. The page 1 is just the attendees. So page 2, 3, 4, 5, 6, 7. Just stop me as I'm going if there's anything. 8, 9, 10, and 11. So we'll take those off an accurate record of the last meeting on the 7th of November. The action log you would have had with the papers. I will go to the executive if there's anything they want to add, but the recommendation against all of those actions are that they have been completed, and so that we will remove them. So that's what we'll do, unless there's anything any of the exec want to add on any of the actions, or if there are any questions from any other board members. Great. Okay, that then takes us into the improving outcomes in population health, which is the board story that we have today. Thank you, Sam, for coming along as Director of Public Health to take us through that. And I think you've also got Anita with you.
So thank you, Chair. We're going to be doing a double act this morning.
So I will leave you both to introduce yourselves and take the board.
Thank you very much. So good morning, everybody. I'm Sam Crowe. I'm still the Joint Director of Public Health for Dorset and BCP Councils, but we'll be moving into a new role on the 1st of April. I'm going to be talking to you this morning about population health, what might have changed locally, a little bit about the national context, but also hopefully we'll have a bit of a discussion about where next for the Integrated Care Board. And I'm going to be ably supported by...
I'm Anita Council, I'm Deputy Director of Health Inequalities and Population Health Management in the ICB.
Fantastic. So I'm going to present in teams, which is a dangerous thing to do sometimes, isn't it? So if you bear with me. Let's see if this
whilst you're looking for, whilst you're trying to get on the screen, just a reminder to you and Anita and anybody else that's presenting later, could you just please think about abbreviations and acronyms? Try not to use them. It is a meeting in public and we want to keep people with us.
Okay,
great.
Thank you. So I guess I'd start by saying this was a big question when Paul, Anita and I first started talking about this a few weeks ago. So what I've done is, this is by no means a comprehensive overview of where we've got to in the system. But I wanted to give an example of why changing population health risk factors is really important. And I think it tells a story about a bit of a model that could be adopted if we're going to be more consistent, if we're going to be more able to sort of deliver resources over the medium term. You can actually see some quite significant change that has an impact on the use of our hospital services, but more importantly, it has an impact on people's lives. So far fewer people suffering from some of these conditions. So without further ado, just going to move on to the current context. I'm sure most people understand this. It's a bit laggy, so bear with me. For some reason, not moving on.
We have got the slides in a pack, so I don't know if anybody else can run it if it's not working for you, Sam.
If I stop sharing, Jane, do you want to try? Because it might just be my network connection. Always a possibility. Take 2. Perfect. Thank you. Right. So just a little bit of context, just as a reminder. In general, the position in Dorset across both councils is that actually population health outcomes tend to be better than England. The exception is that our big issue is inequality. So wherever you look, you will see a fairly consistent pattern of worse health in groups affected by some of these barriers, and that drives our gap in healthy life expectancy, which is between 15 and 19 years. It's important to kind of keep track of demographic change and also the risk factor changes that are happening. And one of the challenges, I think, for an ICB that covers two councils is that sometimes we homogenise the population and the issues a bit. So it all looks like our challenges are demand driven by ageing, but actually that's not entirely true. So we are probably going to have more of a focus on the two places over the next 2 to 3 years. And I've just pulled up the two Chief Medical Officer reports, which I think are worth having a scan through again. So for the Dorset Council Place, the 2023 report about health in an ageing society, I think is really important, not because it's full of statistics about how old we are, which it is, but it starts to set a challenge around how do we think positively about seeing older people and ageing as an asset. What do we do to create the conditions for really, really positive third age living, if you like? And then the one on the left is the Chief Medical Officer's report on health in coastal communities, which I think is really relevant for BCP Council. It talks about a lot of the challenges that face seaside towns. And of course, BCP Council's got an interesting mix of a younger demographic, quite a vulnerable population in some of its more deprived parts, but it is also having to cope with some of those challenges of ageing as well. So it's a really interesting mix. I think by having that more intense focus on each place, maybe we'll be able to drive out some solutions quicker. I'll just make reference to the Health Foundation modelling. This hit the kind of national press a few months ago. This is looking at what health in 2040 might be like, and they've predicted that we will probably see an increase in people living with long-term conditions, up from about 1 in 5 to 1 in 6 in the population. And the largest increases will be seen in people experiencing chronic pain, having diabetes, mainly type 2 diabetes, and an increasing proportion of people with anxiety and depression. And unfortunately, they're also predicting that continual growth in the gap of the number of people who'll be living with these conditions in more deprived areas compared with more affluent areas. So that's the sort of context. Policy is changing. Just a very quick summary. Obviously, there's lots and lots of conversation at the moment around the NHS 10-year plan and the consultation. How does the NHS start to really make inroads into population health and become more focused on prevention? Integrated care systems were, of course, created to try to help with this challenge. I think it's really interesting the way mission-led government is now trying to connect different parts of government, which previously seemed disconnected, which needs to happen if we're going to look at some of the longer-term drivers of health and well-being. So when you think about the importance of work, you think about the importance of good opportunities, you think about the importance of having a good job, economic development, all of that can't be done by single government departments. And of course, this is increasingly being seen through a health lens. And if you look at the Get Britain Working White Paper, there's clearly a commitment to start to look at why are so many people not able to work, partly because of their health conditions. So I'm just going to ask 2 questions today, which is what are the greatest opportunities to improve population health against this context in the ICB? And then what should we be focusing on in a very, very crowded agenda? I'm aware just how busy it is across the whole of the public sector. I think we have to focus. We're not going to be able to do everything, but what can we learn from some of the changes that have happened over the past 10 or 15 years that might give us some pointers? I keep pressing my laptop and as if by magic, slides move on. So I wanted to start with this chart, which takes me back to when I first came into public health. I sort of arrived in the Dorset system right at the start of this chart in 2003. I was a public health trainee and I used to work for the NHS in the Primary Care Trust of Bournemouth and Poole. One of my jobs was to start to support the commissioning team that were looking at cardiovascular disease, and in particular some of the pathways that have been provided out of what was the Royal Bournemouth Hospital. And I became mildly obsessed with the growth in procedures, particularly stenting procedures. This was a relatively new technology, local to Bournemouth at the time. There was a big focus in developing the unit there. One of the arguments that the clinicians were using was that we don't want to see people going off to Southampton for much, much more intensive coronary artery bypass grafts. We can stent people instead, and that should be a very good thing. I wasn't convinced, I have to say. I looked at the evidence, I looked at some trials. I thought there were lots and lots of people who could be managed conservatively with optimal medical management and lifestyle changes who were having stent procedures. And when you looked at the age and sex adjusted rate of procedures, Dorset was doing twice as many as similar populations. We brought in Public Health England. We had strong conversations with the clinicians. Ultimately, we didn't really manage to change that. But look at what's happened over the past 10 years, particularly from 2015. This is all admissions. So this is emergency admissions and elective procedures for coronary artery disease. And even if you look at the numbers, in the last year, we saw just over 1,000 people in that hospital. And that's compared with around about 3,000 to 3,600, which we're seeing at the height of that curve. So same is happening in Dorset, not quite as dramatic a rise in the 2010 period, but we always knew that Bournemouth was doing far more activity. Slide, please. So what could be the reasons behind this fall? It's either a change in pathway or treatment, clinicians working differently, or it's a change in risk factors in the population. Being Director of Public Health, I'm going to plump for the second, naturally. And if you look at what's happened over the same period, smoking prevalence has fallen. So the proportion of people who are smoking in our population has fallen a lot. Physical activity levels have gone up. And there have also been gains in and improvements in diet, but not in all parts of the population. I think it's fair to say that some of the gains from those two changes are probably being offset by the increasing prevalence of people who are overweight and obese. But nevertheless, this speaks to some really important modelling that was done by a research team working out of the University of Liverpool a number of years ago, who actually predicted that this would happen. And they modelled what they thought the change in coronary heart disease in the population would look like. But they also attributed the degree to which that change would be driven by changes in technology, access to secondary care, or change in risk factors. And they said, in their view, most of that gain would be from change in risk factors in the population. Next slide, please. So I think the point of this is that small changes to lots and lots of people at the population level really do add up and can have quite a big impact on the long-term development of disease. And if we can do it for coronary heart disease, there's no reason why we can't reverse some of the issues that we're seeing growing in our population. So I think the question is, what other conditions could be reduced at the population level with substantial changes to risk factors or care models? So I'm going to now talk about the current period and bring us up to date with where I think we've got some really promising approaches of a system approach. If you think about the importance of high blood pressure and the risk of having a stroke in the future, about 3 years ago, when we were starting to do the engagement work around the integrated care partnership strategy, I went to both health and wellbeing boards with a statistic that I found quite out of step with what you might expect for our population. At the time, the first data that we got for the population covered by the integrated care board suggested that our admissions for stroke were among the 7th highest in England, which was a surprise. We were just behind Manchester. Cornwall was up there, but it's unusual because this data is adjusted for age and sex to see that high admission rate in our system. So we started to talk about the importance of finding people with high blood pressure, but more importantly, making sure that people who are already on primary care registers and were known to have high blood pressure had their blood pressure treated to target. Now, if you remember what had been happening in the previous years, obviously a lot of face-to-face care had to stop because of the pandemic, and our data in Dorset wasn't great if you looked at the proportion of people who were being treated to target. There's a national target for all of the areas in England to identify 80% of the people with high blood pressure and treat them to target according to the guidelines. And so we began to talk locally about what would need to happen if we were going to reverse some of the pattern of what we saw. We started to talk to communications and engagement teams about developing a Know Your Numbers campaign, which was very successful, and it eventually rolled out across the whole of the Southwest region. In public health, we restored our NHS Health Check programme, which is quite effective at finding people who don't know that they've got high blood pressure. That had not been in a good place since the pandemic, but in the last couple of years, we've successfully invited and seen about 10,000 people in each of those years, and that's helped to drive up the numbers of people known to primary care with high blood pressure. And the proportion of people with high blood pressure who have it successfully treated and under control has also really improved in Dorset. And that's because of focused effort through the commissioning local improvement plan. So primary care commissioners have been saying to practices, we will work with you, we'll incentivise you to understand who's not in that group and how can we support you to close that gap. Next slide, please. This is what's happening to the admissions. You can see on the BCP Council side, we have that sort of peak as we went through the pandemic. But the last data point we have, which is relatively new data, suggests that those stroke admissions are starting to come down quite significantly. So if that pattern is maintained, that will be fantastic news. It's quite a significant drop. And again, you can see on the Dorset Council side, there's a bit of a peak as we went through the pandemic years, but that's come back down below the average for England. So again, starting to see some promising signs of real progress there. And the point about these approaches to what's called secondary prevention is that you can see change quite quickly. This doesn't necessarily take years to accumulate the benefit. If you can get at the population level, most people with their blood pressure controlled, you'll have a real impact on the number of strokes that we see. I think I might be handing over to Anita.
I think so. Now, it's been pointed out to me that I have got a very quiet voice. If you can't hear me, please do wave at me. I've got my reading glasses on, so I might not see you first time. So Sam flagged there some of the work we've been doing in the ICB to try and work with primary care with PCNs and practices to help them improve how they help people to identify, but also to treat, to target people with high blood pressure. And one of the things I want to reflect on is that when you do that focused piece of work, you can, in a very short period of time, start to make a difference. And using what we call a population health management approach, and starting with data, and some methodology, taking people on a journey, you can start to make some real shifts in that. So this slide just shows that we've come between December 23 and September 24. You can start to see the numbers we managed to plan. So the hypertension shouldn't cause them to have a stroke as well managed. It's not a shift from the person well treated. We do still see some variation. We're seeing improvements though in some of those groups that have poor outcomes generally. So we're seeing midlife men possibly having some improvement overall in management. We're seeing some ethnic groups having some improvement as well, so improving faster than others. We're starting to see in the data, early days, that tracking through some progress from that early action. And there's been an awful lot of hard work in our PCNs, from our clinical leads who are put in place in our PCNs for CVD, hypertension prevention, to really make a change in how we can use digital technologies, crunching the data, and seeing about it. And the next slide just deep into that variation piece. So on the first one, this is national.
You're getting quieter, Anita. Do you want to increase?
On the first one, it's just national variation by deprivation quintiles. So again, we can see that the most deprived do still have poor outcomes. We're getting some traction, some improvements across all the deprivation quintile, so all the fittest population deprived, and slightly more improvement in those deprived groups, early days. Again, we've still got variation by different ethnic minority groups, but on the slide later it shows some green shoots around that. And we've got variation by age. One of the interesting things of this is that the anecdotal information was that it's very hard to improve hypertension in Dorset because we have many older people. It's very difficult to get improvement in all very older people, largely because of the number of drugs that are. But actually, looking for data, we found that the quickest improvement was in the very elderly, and those were best managed. Exceptional people in midlife and people of working age and working age men and ethnic groups that have post outcomes. So that perceived wisdom about why we couldn't get a change, actually looked at the data, showed that we could do, and practice were doing a phenomenal job with other people. And deep diving into their project populations, making their own plans and their own targets and ambitions was the way we started to see some change in that. The next slide again just shows, okay, it could be a national picture of improvement. Sam showed those slides around nationally, how CVD indicators are changing nationally. So this is a national effect and nothing to do with what we've been doing. The table here is a comparison of Dorset hypertension management compared with other ICBs nationally. The top bar chart there shows we're about the 4th worst in the country. They have been bobbing around that for some time. The data today, which is June this year, it's been published very late nationally, shows we made a step change. Again, early days, one quarter does not make, but we're starting to see some real change in this, and we've gone from lowest quintile to mid-table over a very short period of time. So we take some optimism from that, but not surety. And that bottom chart there with a black ring around it, that's showing variation in that population, in that quarter, between different ethnic groups on the national data for Dorset. And again, green shoots, but not definite. So that red circle there is around the black population. That's the category used nationally. We're starting to see a quicker rate of improvement in that population. And I think that's because practices now understand the variation in that group and starting to pull out those population groups, focus on them. And similarly, the line above is for the mixed population group. Again, early days, we're starting to see some shift in that. So we're hopeful that trend will continue and we start to bring all of our Dorset population groups back up to the Dorset mean and up to the England average and beyond. So Sam's going to take us through, if we use this kind of methodology in future, what kind of difference can we make and what are the opportunities around that?
Thank you, Anita. So you can see we've got many pieces of the jigsaw, I think, in place to start to think about how we would systematise this approach to improving some of these population risk factors. If we're going to do population health management at scale, we're very, very lucky in having the Dorset Insight and Intelligence Service, which will allow teams to understand what are the local groups that are perhaps not doing as well, and more importantly, to have conversations about approaches that might be right to start to close some of those gaps. As we start to develop those integrated neighbourhood teams, if we can start to shift resources to enable those teams to work differently with key groups, then I think we can really make a much more impressive change to date. One of the challenges is that if you sort of break down some of these groups with, say, for example, blood pressure or type 2 diabetes at the level of an integrated neighbourhood team, in simplest terms, there are perhaps 4 different groups. There are people who are very, very engaged, who know their condition, who don't need any persuading to read up online, to engage with patient organisations, to manage their condition, because they've decided that that's the best way of improving their health, and you don't need to persuade them. There's something about how we can provide the support services at scale so that they don't need to come to a practice anymore. They don't need to check in. They can do a lot of that self-management using some of the existing digital tools. So a light touch check-in and the conversation would be more about their self-management rather than their condition. There are groups who still engage but struggle to reach control. I think some of the conversation that a neighbourhood team could have is much more around non-medical support. Are they exercising enough? What's their diet like? What's their alcohol like? All of those really, really difficult issues, which sometimes in a busy clinical environment are quite hard to tackle. But an integrated neighbourhood team can have more people around it that can put the time in to perhaps raise some of these issues. With the group who may be not reaching their control, living with some of these conditions and not engaging, we need a completely different approach, which sometimes the evidence says is best when it's peer-led. So rather than the clinical team trying to have that conversation, who else is around in those social networks who might be living with that condition? They might have lived experience they want to share. Sometimes that social network approach is the best way of starting to engage people and change their mindset about the importance of actually taking their condition more seriously. And then the final group, which is perhaps the hardest, are the people we don't know about. These are people who are not yet diagnosed. But again, engagement is usually best through known and trusted networks to them, not necessarily through professional services. I think my final comment is about the potential of elective care reform. I think it's always a challenge in the NHS when longer term we've got aspirations to work upstream, to shift resources towards prevention, to shift resources from hospitals into the community. But meanwhile, the drumbeat is always waiting times, elective care, urgent and emergency care. But if you look at some of the models that we started to develop as part of the outpatient assessment centre in Southwark's House and also for a time in Beals, I think they're worth revisiting. And this question of how you invest in people who are waiting well so they've got the best possible chance of having a good outcome from their procedure when they finally do get their operation. But more importantly, it's a really, really good window to raise some of these issues around lifestyle, so that not only do they recover well, they have a better chance of recovery, but it sets them up for a much, much better outcome, particularly those in midlife and beyond. So there's a question for me about the extent to which Dorset ICB could invest in the future in waiting well initiatives. Now, we didn't get everything right in the outpatient assessment centre. I think that clinical model is quite hard to sustain, particularly when there's a lot of pressure in the system, because clinicians do get required to work in and around the hospital. It gets very, very busy, particularly over the winter. But I think we've shown that there are some clinical leaders locally who are really, really keen to have a much more collegiate approach to the way that some of these consultations are run and involve a true multidisciplinary team, physiotherapists, physical activity coaches, lifestyle coaches, as well as the orthopaedic surgeon. Next slide, please. So just a couple of suggestions as to where we should focus in a very crowded agenda. I think we've shown that secondary prevention, when done well at scale, building a consistent approach to identifying disease early, putting in some of those interventions around better control. If you can shift that so that it's more person-centred and systematic through those neighbourhood teams informed by our intelligence system and the evidence of what works, you can show that significant change can happen over the period of 10 to 15 years. Sounds like a long time, but in the scheme of things, that's actually a pretty short time scale. The second point is to drive down inequalities. This is the area in Dorset with the most potential for health gain in the population. If we can lift some of the segments who are furthest behind and close those gaps quicker, we will start to have a real impact on that gap in healthy life expectancy. And that's probably one of the most important things in our population, because on the whole, we do tend to do better than England. In terms of primary prevention, or the things that you can do to stave off your risk of any of these long-term conditions happening, the most important issue to get right is physical activity at scale. There is a really interesting debate going on at the moment about some of the weight loss drugs. And I was listening to someone on the radio earlier on in the week who was describing some of the newer varieties as holding great promise because they could have an impact in diabetes, they could have an impact on obesity, they could have an impact on lots of other secondary conditions, if you like, that you can develop as a result of being overweight or obese. It sounded like they were talking about physical activity. All of those benefits stem from being more physically active, demonstrated time and time again in big population trials. Finally, those wider determinants, the long-term drivers of health and well-being, are important. I think it'd be interesting to keep an eye on devolution. The creation of strategic authorities, I think, gives us a chance to start to think about how could we do economic development better at scale. How do we get into some of those issues like health and work, the future opportunities for people who otherwise sometimes are left behind? Those are really, really important for closing the gap, and increasingly should be the business of the Integrated Care Partnership. Next slide, please. So this is just to show the different timescales of the different approaches to prevention. It's just a very quick reminder. What I've been mostly talking about is the dark blue triangle on the left-hand side. So this is treating people with established risks and established conditions already. The conversation about primary prevention and things like physical activity is the orange triangle in the middle. And what I've just referred to, the promise of tackling those wider determinants, is the long-term agenda about really improving the conditions that drive health and well-being and prosperity. Slide, please. So I'm going to hand over to Anita now, who I think is going to talk about what next for the Integrated Care Board.
Oh, particularly on questions to come back to at the end, if someone reflected back on those questions at the beginning. This was really to reflect a couple of things. One, of course, we're not starting from scratch. There's lots going on in the prevention space already. We have an existing cross-system partnership group that's just been stood up to start looking at what we do around this prevention at scale, Mark II model, building what we have before, and starting to think about all the opportunities that we have, both in terms of primary prevention, secondary prevention, and tertiary prevention. These two triangles here show on the left-hand side, that's the typical model we think of: the small triangle, secondary prevention, bigger of primary, and wider determinants. What we're doing in this is thinking, actually, what's the particular role, what's the unique opportunity that the ICB and the NHS has around the prevention pathway? And that really tips the triangle on its head. We've got an opportunity to use secondary prevention as treatment. As Sam talked about, how do you bring together multidisciplinary professionals to really think about all the things on the menu of things that help people to avoid exacerbations, to remain well, and not develop second, third, fourth long-term conditions that we know are the things that cause, particularly most deprived population, to die many years younger and live more lives in poor health. How can we identify our unique opportunity and make the most of it? And those kind of things from the evidence base of what we're talking about with partners now. How do we offer different kinds of support to different kinds of people who need their need? The kind of model Sam's been talking about. How do we really use making every contact count at scale and en masse? How do we really sweat our opportunities and make the most of those in the health system? And in doing that, some of the evidence suggests not only impact on reducing exacerbations, but actually on a whole range of other demand and need pathways, because reducing people going to the next stage of severity to are often very small and very doable interventions. So how can we, the system, start to build the opportunities across all of our work and with our partners to do that? As we go down that triangle on the right-hand side, of course, the NHS is in primary prevention. We see well people want prevention. So we've got lots of opportunities. People who are actually in general well, and we can have primary prevention perform our work. And of course, we can work with our partners on those wider determinants for a relevant institution. But we've got a real opportunity to focus in, think about those timescales that Sam mentioned, where we get payback for prevention in a 5-year timescale, to really focus in on what we can immediately do in ICB, with NHS bodies, and what we can do that will give us a quick payback for our efforts and really start to make a change, as well as some things. I think what next questions are really for consideration by the board, and I don't think I can flake back to those first questions that Sam flagged up, and I think a second slide.
Small.
Yeah. So what are the greatest opportunities to improve population health in this context for Dorset, and what should we be focusing on in a crowded agenda?
If you want us to focus those two questions now.
Yeah, happy to either pick up any questions that people had from the information we've presented today, but also I think these two, for me, are key questions for the ICB. And because it's so crowded and so busy, there's something about, where do we do the business in quite a busy landscape. But secondary prevention is an area where the NHS has almost complete control. And that's the bit where I think we've shown that when you put a number of pieces together, engagement, communications, supported by information and intelligence, a different range of interventions to suit people within that group who may respond differently. If you can scale that up, there's no reason why we couldn't tackle after hypertension, type 2 diabetes. There's no reason why we couldn't go after some of those other conditions, which we know are going to be increasingly common in our population. But it's the gap that I'm most concerned about. How do we lift everyone, but lift the lowest groups the quickest?
And just to add to that, in that context, think about the whole mixture of things, because we can talk about lifestyle interventions, but actually many people are talking about have so many other things going on in their lives that they don't have the same opportunities to live a healthy life or to make healthy choices. So how in our intensive intervention we're building knowledge of the barriers that people are facing and to address those by having different intensity of support offer and not one size fits all, and to create the capacity for that by thinking about some of those, for example, digital self-care interventions, which some of our populations, those four categories that Sam described earlier, are well able to get on their own. Let's not get anywhere with those people. Let's let them do that, and let's focus our resources, or should we focus on resources? I suppose it's a question. On those people who need the most intensive support offer, having different degrees of support, both in understanding what will help people to have their fair and equal outcomes, not a one size fits all approach.
Okay, we've got just over 6 minutes done for questions. So if we can go to that now, and I think Matthew, if I take you first.
Okay, thank you. So quick comment. Really great way to begin the board meeting. I think we're going to see this theme throughout our day to day. It's good to be beginning with this and ending our part 2 with INTs. My plea would be this data is great. I think we need more of it to guide our discussions within the INT. When we look later at the medium-term financial plan, this is exactly the kind of data we need. I think we've got a challenge here around measuring what we do in terms of value for money outcomes, because we've got some very narrow focuses on productivity at the moment. And we need to recognise that actually what we're achieving here through investment in the third sector, through investment in primary care, through investment in a neighbourhood health service, will actually deliver better outcomes for people. I think the way to marshal effort behind it will be to prioritise on particular things that we want to do. And it is about empowering citizens to help people live healthier lives. And just a really big vote of support for physical activity, which there's so much evidence for and has a big impact on mental health outcomes as well as physical health outcomes. So I'd like to think maybe about how we marshal around that. And maybe we could become an exemplar as a board, and in our next development day, rather than sit around a table all day, go for a walk either in BCP area or around Dorchester to actually go and see some of these things that are happening and making a difference for people.
Thank you, Matthew, and a really good challenge there at the end. So Keith, you're next, and then Patricia.
Sorry. It's double clicking.
We can hear you.
We can hear you, Keith.
Oh, good. So, I mean, actually, Matthew said many of the things I was going to say also, and also the irony of us sitting around here all day when we know the benefits of exercise wasn't lost. I suppose the only other thing that I would add is, I think when we looked at behavioural change more widely, there are lots of sectors that have looked at things like, how we nudge people into different behaviours and those sorts of things. And I think sometimes we tend to be a bit stratified and we think, what's helped for exercise, but there are lots of examples of changing behaviours in more subtle ways, and maybe we could look a bit more widely at some of that sort of psychology work around nudges and those sorts of things.
Thank you. Patricia?
Thanks, Sam and Anita.
It's really thorough, thank you. Three things going through my mind. How do we embed secondary prevention in all the work we're doing around transforming care? Because we will be looking at every service model. So I think we need to think a bit more carefully about that and the approach to that, and the outcome-based commissioning framework work that David is doing to move that forward in the next 12 months is going to be absolutely critical to some of that. I'm really struggling with health inequalities and social determinants being separate because they're so intimately linked to each other. David and I I was telling Graham this morning, we had a meeting on one day this week with an organisation called the Local Trust, who been doing some work with us with the Confederation on neighbourhood working and community asset building. And they do quite a lot of work based on the findings on the Community Needs Index around assets versus deprivation. So I think there are some opportunities for us to use the information on that system with them to look at working more closely with local authorities and where we target some of that effort around health inequalities and particularly social determinant work and how communities can be self-driven on some of that. And then physical activity. We've obviously got the queen of physical activity here in Charlie. So how do we really think about how we build some of that into the work going forward as we really progress with the work at place and neighbourhood level? And also thinking really carefully, given that the likelihood is that one of our priorities next year from the JFP is going to be obesity, particularly in children and young people. How do we really think through the benefit or the contribution, significant contribution that physical activity can make to that if we get that programme of work right, because that's about planning for the future.
Thank you. Then I've got Paul, Kay, Dan and Forbes, and we'll cut the questions off there and come back to you, Sam and Anita. So Paul, isn't it?
So a couple of things. First of all, thank you. And I know that the focus there is on cardiovascular and hypertension. In a way, that's in theory, it should be really easy to do because we know what the numbers should be. There's a really good evidence about what you do about it, and there's a really straight line between controlling it and the impact. And yet, post-COVID, we have struggled to get proper traction and get control of it. And it shows just because something on paper is really straightforward. Often the complexities in our populations and the complexities in competing demand just make it really difficult. And I think as we move away from something like that's really easy to measure, it only gets more tricky. So I think let's not underestimate how much we need to make sure that we don't lose the focus on it. I remember when I was training to be a stroke physician, someone showed me a photo and it had Churchill, Roosevelt and Stalin in their meeting. And all three of them, that's your risk factors. There's obesity, smoking, physical inactivity, alcohol, and all three of them died of strokes. And so it's quite stark that actually it's all presented there. And there's a really good success story in the NHS over the years, but we've stalled. How do we make sure, and I think this is going back to the question, that's my digression because that's stuck in my mind. We're going to be looking at a number of clinical pathways, and there is a risk that we restrict ourselves in patching up where the issue is bubbling out. And it's often bubbling out because we've got too many people in the outpatient, there's too many people waiting for surgery, too many people knocking on the door of the GP. But if we are really clear and set our expectations in ICB that and as a system, that when we look at any pathway, that there has to be an equal focus on what we're doing with established disease as to what we're doing in that prevention space. And I think we set that expectation and expect to see that coming through in the priorities and the work plans that these kind of people develop, these teams develop, I think will be really key.
Thank you. Okay.
And I was just very quickly, anchor organisations. We're anchor organisations. We have a huge number of staff. And our staff, our population here as well, and they will be just as susceptible to some of these things and just as amenable to some of these lifestyle modifications. And so we mustn't lose track of that as well. Sorry.
Perfect. Thanks. Apologies for cutting off in your prime there. Kate?
To some extent, I'm following up on what Paul was saying there. I just wanted to give a shout out to the work that's being done in changing clinical culture and processes in some areas, and particularly with respiratory and CBD. I mean, quite rightly, you pointed to the long-term changes in behaviour there that supported it with smoking and such things. But also there has been a considerable gain. And I know to some extent it was low-hanging fruit, but there's been a considerable gain in the priorities that we have set amongst changing the way clinicians look at certain aspects of respiratory or CBD. And the key thing is going to be, as we move forward, what's going to be our next priority for that, because you can make what may look like small steps, but they can make a significant change. And certainly when Martin Longley was presenting on CBD, you could see the beginnings of those significant changes. So the long-term determinants, such as physical activity, and that, it's hard to make it. It's slow making a difference, but you can get some quick wins in changing some of the clinicians' cultural and behavioural ways of working, and that should be thrown into the mix as well, because I think we've made some good progress there, and we shouldn't forget that we've done that.
Thank you, Dan. Then Forbes.
I'll really brief, there's 1:30 looming. Thanks. I was really taken by slide 15 in your pack. And I was just thinking about visual stuff that we can use to prompt us as a board to think about this. And it's a really helpful kind of graphic. I really agree with Matthew on kind of prioritization and doing things in bite-sized chunks and things that deliver tangible benefits rather than trying to take it all on. And then probably kind of morphing a little bit into ICP territory rather than ICB. I was thinking about the outcomes of population health. Clearly, it's the purpose of an ICS to kind of go after, but really the employment, the economic benefit, the stuff that you covered in your slide deck, it'd be good for us to consider as a board what population equality and health actually does for the local area. So it's kind of to really understand the true outcomes above and beyond our statutory role. So comments rather than questions.
I mean, a lot of it's been covered. You know, it's always really helpful to see this because the evidence is very clear, it's very stark, and it's irrefutable now, isn't it? You know, in terms of the value of getting in early, getting upstream in these conditions. That is what helps the population. Building another catheter lab at the hospital to increase the intervention rate is not what it might help the individual, and we should support that, but it doesn't help the population. As a whole, I think, you know, Matthew's made the point. I think we need to look very quickly at, you know, our commissioning intentions, which are commissioning shared outcomes through integrated neighbourhood teams across the community. And these will be differential according to needs. You know, that's basically where we need to get to based on the information that we have on DICE. I think the other risk and the bigger challenge that we have is we've got to stop medicalising all of this. We've got to stop it. The conversation at the moment is about how do I get obesity drugs, not about how do I prevent obesity. Through the media, and it's now pervading society. And I know there's all sorts of issues around it. You know, and we see it every day. But this is where, as a collective within the public sector, I think we have to be much stronger. Health can do its bit. The local authority can do its bit. Education can do a huge bit. And I know everyone says it's difficult to get behaviour change, but there's got to be some collective approach to doing this. Because that's the issue here. That is absolutely the issue. Because when people come to me, I can help to lower the blood pressure with more drugs, and I can help to help with more drugs, but then we're told we're over prescribing and drugs are not the solution. And we've got to get even upstream of the primary prevention interventions that I, as a GP, can do and look at lifestyle choices that people are making across the population. And I know it's hard, and I know there's all sorts of reasons, but that really needs to be the debate, I think.
I wholeheartedly agree with that last intervention. Can I just add one thing, which I think links to that, but also some of the others, which is, Sam, you mentioned the outpatient assessment centre and the fact that, you know, there's lots of learning from that. We need to kind of evolve from where we started. So the question for me is about how do we build agility into the way that we work so that when we do get the learning, we can quickly adapt to keep the momentum going, because otherwise things just wither and then we move on to something else. Right, I'm going to give you 30 seconds, both of you, if you want to respond, and then we move on.
I guess I'd say thank you for the really helpful comments and insights. I can't possibly answer them all in 30 seconds. If I was going to have a go at it, though, I think this is about what I call classic multi-level interventions. So the bit that connects the importance of wider determinants through to what actually happens when you're having that conversation with the individual is making sure that we're really consistent and that the whole of our public sector locally is aligned in a very, very clear strategy. So the longer term stuff will rumble on, and I've made that reference to perhaps ICP and devolution picks up on some of the big levers. But Matthew mentioned neighbourhood. I think you called it a neighbourhood health system, didn't you, rather than an integrated neighbourhood team? And that's a really nice way of thinking about a local ecosystem where you can use asset-based approaches. You can work with other partners who might not necessarily be professionals to have some of this improvement in a non-medicalised, asset-based, strengths-based approach. But the point is, at some point, we've got to have an aligned strategy where we're saying lots and lots of different organisations can bring little bits of what builds into a comprehensive strategic approach. And the more we can set that out clearly at the start and have a real intention about what we're doing, I think we'll find it easy to get people on board. And obviously it will be different and it will look different at different levels in our system.
Thank you very much. Thank you. So I'm going to move us on, just conscious of time. We're now going to go to the board assurance framework, which is the first of two items that we have here for approval today. And David, I'm going to hand over to you to take it.
Thank you. Thanks, colleagues. And Chair, so I thought that was a really super helpful presentation, and I think we'll see a lot of the threads of the importance of paying attention to inequalities and prevention through lots of our discussions, including here in the board assurance framework. If I could just just take a step out of that for the moment. So this is part of the regular presentation of the board assurance framework, but the board will recall at the last round of committee meetings and meeting of the board that we were introducing plans to review and further develop the board assurance framework. And we have been working with our auditors, BDO, to review the current format and also to review some of the examples that other ICBs are using to see if we can learn from their best practice. And what we have found is that within this board assurance framework as it currently stands, there's some really good elements of good practice. And in fact, in some ways, we're going beyond what many others are doing. But also we did notice that there were some things that others were doing that we need to learn from and we need to bring into this board assurance framework. The biggest shift, which I think we recognise and has been underscored by those reviews, is that we need to more clearly define our strategic goals and objectives and plan our board assurance framework around those, rather than at the moment it's based on our statutory expectations of us rather than clearly defined goals and objectives. And we had been planning to run a board development session around these sorts of things in February. However, the critical path for getting to that point has changed because the national guidance around our operating plans for next year, the medium-term plan work that we're doing, and the strategic refresh work that we need to do as well can't happen before February. So it makes sense to move that development session to our next opportunity to consider at board, which will be in April, which will be post those other things. So the critical part is we need to be clear when our strategic goals and ambitions are based on the national policy, our own internal strategy refresh before we can get to the board assurance framework. So in line with what we said last time, we will continue to maintain the board assurance framework in its current form, encouraged by the review work that we've been doing with BDO, and also the board assurance framework as it currently stands, whilst we might reshape and define the key risks, it is still covering the ground that we need to pay attention to in terms of our strategic responsibilities to the system as a whole and our population as a whole. So for this board assurance framework, it's gone through the usual process of the chief officers reviewing and updating the BAF risks. It's gone through the relevant committees that have reviewed before the final consideration of the risk and audit, and it's come here for the board today for its final round of approvals for this cycle of reporting. So happy to take questions, obviously, and we may pass to the individual chief officers if people want to drop into a bit more of the detail about each risk, but it's presented here for the board to approve.
Okay, so can I just steer from the perspective that because we've still have more development to do on the back. And you've heard David suggest that's going to be April now rather than February, that we bear that in mind. If there are any questions around the strategic risks as they're presented here today, then let's cover that, but let's not get into detailed discussions itself around the BAF. So, questions, comments? Okay, I think between your paper and your introduction, I think you've covered all that was required, and you've actually got us back on track time-wise, so thank you very much. So, Patricia, I'm going to hand over to you for the Chief Executive report.
Thank you. So I'm going to take the report as read. I'm not going to go through it in any detail. The things I think we need to pay particular attention to are the winter pressures that we're currently facing. As expected and predicted through the public health data, the week between Christmas and New Year was incredibly busy. We have a small number of escalation beds open and we're working hard to close those as quickly as we can. Obviously that may have an impact on our finances, which so we need to close them, but we need to close them safely. The general practice collective action continues, although I have to say it is much less severe in the Dorset ICS area than in other parts of the country. That doesn't mean I expect you to whoop it up to a different level, Forbes, but grateful that we are where we are in terms of our relationships. The national negotiations around the GP contract continue. There has been a letter from the Secretary of State before Christmas with an initial offer, but the negotiations continue with the BMA principally because there is no indication that that offer includes support around the additional national insurance contributions for employees or the pay award that applies to Agenda for Change staff at the moment. As was mentioned already, operational planning for 25-26 now is going to be incredibly tight. We still do not have a financial envelope. In fact, none of the 42 systems have a financial envelope yet to work with in terms of securing contractual positions with partners and understanding what money we've got to commission and transform services. You'll see in the discussion we have in part 2 this afternoon, that's about defining the way forward in terms of how we might manage those conversations and negotiations. What we do know is that the NHS will receive a 2% real terms reduction in funding 25-26 onward. That makes things incredibly tight. We also know that we're expecting elective activity reform, which will mean a 5% productivity gain for the same finances that have been funding that's been used this year because elective tariffs will be reduced. So there are a number of things now that's starting to come together, which mean that even though we don't have the defined detail of the planning guidance, that we're heading into a very difficult year. And so the things that we've been working on in terms of increasing our productivity, which is still way away from where it was before COVID, making sure that we are demonstrating value for money in terms of how we're using our funding, and delivering on the key transformation programmes that we've already started this year around the UEC work, around the integrated neighbourhood working, and the new hospitals programme, that we need to bring those to a conclusion safely, but in the most cost-effective way that we can, and make sure that we do realise on a cash releasing basis the savings that we've all committed to. Make any questions?
Thank you. Questions or comments for Patricia, either from what you've heard or what you read prior to coming to the meeting today? Sam?
Just on the winter pressures, it's not so much related to your report, Patricia. I'm just wondering if it would be worthwhile doing a very quick look back around things like flu vaccine uptake in key groups. Because I've got a feeling that it hasn't been as good as in previous years. And that's not surprising because we've changed eligibility after the pandemic. But I think as a system, it might be quite helpful just to do a quick look back and then see what more we could do in September next year.
I think it'll be useful to get a bit of more of an update today if we can, so we can either do that towards the end of this, or when we get into the IPC reports, as I said earlier. But I think a formal review would be helpful. So I've got Dan and then Cecilia.
Just a comment. It's a really helpful report, and I always read it as this is the stuff that's going on and you should be updated on as board members, and that's incredibly helpful. I went back and read it again at the end of the pack when I looked at risk and kind of been through the papers, and it just made me think, is there anything that we could or should be doing in it to kind of align it to strategy a bit more and align it to risk? And so the thing that jumped out at me was electronic health patient record. I probably got I don't want to use an acronym. It's picked up in the UHD update, but not in the ICS update. And then I was just thinking about the UEC, the urgent and emergency care working part 2, and kind of that big live risk we're dealing with. And is the objective of the report to note stuff, which is helpful in its own, but the kind of risk and strategy alignment, I was just reflective of that. And so I share that as a comment rather than a question. And it might be it does what it needs to do. But going back to read it again at the end of the pack gave me a different kind of view on it.
I think we talked about that a little bit at the notes, and I think I think we need to think really a bit more carefully about what partners updates are here for.
Yeah,
because they're not just about saying to everyone this is what we're doing really well. It actually needs to correlate with what's going on in the system and what everyone's contribution is to managing some of those challenges. I haven't raised EHR because personally I don't think there's anything to tell you yet. We've got an outline business case, it's gone off for review, and when we get it back we'll be able to give you an update on it. So I think we need to think a bit more, and when we distribute the report for partners to contribute, we need to be a bit clearer and or a steer around what those contributions are.
Thank you, Cecilia.
Well, I just wanted to pick up on one of the things that I thought was one of the good news stories that you've actually highlighted in here, which the early cancer diagnosis, which seems to actually fly in the face of what one hears in the press. I mean, the press is all about late stage people not being picked up, and yet clearly that's not the narrative, that's the facts on the ground. And I don't know how you change some of that, because it reads as a very, it's a positive story for us.
It's true. It's not national media messaging. Yeah. What underneath that is not just a lot of work on the general population, but on really vulnerable groups. So for some of our populations that have LD or neurodiversity issues, with some very concentrated work to support those communities to move on. Yeah.
Or did you want to come in on that, or did you have another point?
Well, I think you're right. I think there's a couple of things that really have come in as game changers that we're reaping the rewards for. One is the fit test, which is now part of the new bowel screening, and the threshold has now changed to try and pick up even more people earlier on, but also for people with symptoms, so that we can do the screening without even though we haven't got the capacity to do all the endoscopes that we would have had to do in the past. And patients are much more amenable to that because it's a simple stool test rather than invasive. And the other one is targeted lung health checks for people at particular risk. And I think both of those, well, we've got evidence that both of those have helped us pick up earlier diagnosis, particularly in those conditions. We've still got to find a way. So there are other conditions. So prostate is one where we've still got work to do because we lag behind our neighbours in Hampshire. But those are the ones that are driving that kind of performance.
This is where we could tie in with what we've heard about this morning in terms of what more could we be doing to help identify those folk, especially if it's the hard to reach identify and being able to be accessed in a way that other areas have been able to do.
Okay, don't see any more hands. So did you want to say anything at this stage, you or other members of the system around winter and how we fared? So
I think Dean's already doing some work looking at what the impacts of vaccination rates have been. Some of it we know has been about flu, don't we, Dean? But quite a lot of it hasn't. So it's not fitted the national picture, and Dean can comment on that in more detail. I think we've got to use the escalation process, the control centre process that Dean's put in place, which has really helped us keep this situation as tight as possible in bringing partners together when we need to. And the regular meetings that Dean has at place level with all partners are really starting to bear the fruits that we'd expected in terms of how we move forward. What I do think we've got to do more work on in the future, which we've talked about already, is looking at what the region is starting to develop in terms of that dynamic risk assessment process, and how can we use that and develop that and apply that to the Dorset system. So we're absolutely clear when we do make decisions that mean that we're prioritising different parts of the system for very good reason. We've got the evidence to support the decision making in case anything happens, but also in case we don't make challenge policy.
So, as a short thing, would you say that our plan survived the battle? Did it actually operationalize in the way that we had planned and hoped? And then I'll bring Siobhan in, because obviously this is all part of thing. But Dean, do you want to?
Siobhan and Matthew will have been at the sharp end of that, but I think what you can see kind of from my slightly kind of more distant view, just looking at the data as what's happened, is that we had a really big peak between Christmas and New Year and just after, probably bigger than we've had in previous years. Our plans did survive the contact with reality, but it was really difficult on the ground in managing those few days. Our number of escalation beds, which was our big one of the indicators of how pressurised it has been, shot up to double to what it has been. So we've been at the 30 level. It went up to 60, 70 for a short period of time, but we have come back down to that level that we were experiencing before Christmas. So seems to be a relatively short, sharp shock there, but we're still having to recover from that. And the big area that hasn't yet recovered is no criteria to reside. They're the numbers that have gone up. Now, you would expect that, because actually from the admissions that you get over Christmas, it will take kind of a week, 2 weeks, 3 weeks for those individuals to be ready to leave. So we're in that real busy period. We have the East weekly improvement group meeting where the ICB, BCP and UHD come together. That will be a focus of that meeting, because there are over 200 people now waiting to leave UHD. It's more than it was before Christmas. Half of those are ones that can go straight home. They aren't going straight home yet. We need to put some more work into that. There's lots of other things I guess I could say. There's the Newton work, the bit that's going to affect that, the transfer of care hubs, is the first bit that's really coming to fruition, because of the long lead-in time that we had with the other work previously from the Better Care Fund in doing that. So there are some early signs. I think one of the things that was indicated to me was we didn't call any gold calls over Christmas. We managed it because of the processes that we put in at the operational level. With the work, we used the weekly improvement group meetings on a Thursday to be that more strategic level, to kind of what's happening over the next week, the week after. But the day-to-day was largely managed through the great preparation that the trusts have done in doing that, and the system preparation that we've done as well.
And I think that, just to add that, SWAS were under extreme pressure. The points at which our regional stack of calls waiting hit the 500 mark, they were in extreme pressure. But what we did see is that pressure was not reflected in the Dorset system, because of the planning that we're doing at the same level that it was in other parts of the region. Our CAT2 calls at times went up, our handover delay times went up, but nothing like to the levels we've now in other places, regionally or nationally. And that's about effective planning and the response from people that is quick and professional, with safety in the back of their minds.
Okay, I'm going to bring in Siobhan, Cecilia and Pam. Actually,
Hi, morning. Do you want to take Pam first?
Okay, go on, Siobhan.
No, I was just going to say that obviously we're still in winter, and if I look back over the last 6 weeks, as a system, I think my personal view is I do think actually, compared to last year, and I've been in this system for 3 years, it has been marginally better. However, we were hit by quite a severe flu influx. So the flu vaccination is interesting because I still think we've got quite a lot of resistance in staff in hospitals to having flu vaccine. And that is different from where I was in London, just interesting. And we continue to promote it, and we're continuing to encourage people to have their flu vaccines now. But in terms of what people are tired as usual in winter. I've come in today and we've got 32 patients waiting for beds across the 2 EDs. But we have no one waiting in a non-clinical area today, which I think is really good. We've had times when there have been, and we've had lots of debates about how you mitigate and make sure patients are safe. My big concern is probably I've got 30 escalation spaces open today, which isn't in our winter plan. And I think that does potentially give us a bit of pressure around our financial plans that we've got to work on and mitigate. But our same day emergency care areas are not bedded. And that is really good because that means you've got flow. And also we've reduced our length of stay over the last year by 0.6 days, which again is good. But the work of Newton is going to be fairly critical in helping us get people in the right place in the system, because having no criteria to reside that is so high at the moment against a much lower trajectory gives us a real challenge. But I think compared to what I'm seeing in the newspapers, which you can't believe every day, we as a system are doing a pretty good job at mitigating and working with the pressures together.
Thank you, Siobhan. Cecilia, then Pam.
My other point is not in relation to this topic. It's really looking at the comments that were made about the national insurance contributions, the impact that is having.
All right, so shall I just see if Pam's is about this discussion?
Thank you. Thanks, everybody. I think it's would be remiss of me if I didn't just draw your attention to the RCN report that's been published today around corridor care. And I think it's really important for the board to recognise that nobody normalises corridor care. That is not the starting position. And certainly for the Dorset system over the past few weeks, when that has happened, it has been brief, but also it's been a very collegiate approach, because there is a recognition that there are patients out in our community that our ambulance services still haven't got to. And I think that was the collegiateness of the approach, I think, really around recognising that shared risk across the system and how can we help each other as partners in that. But really just to confirm that when there is corridor care, and I know in the national media there is a suggestion that there is a normalisation, that is not the case. I think it's more about how do we share risk right across the system in the urgent care pathway.
Thank you, Pam. That's really helpful. Cecilia, your question, and then we'll go to
my point was really about, it's been raised in the, I think it was the BCP Council report about the national insurance contributions, and obviously the impact that's having on local businesses, local small businesses, social care businesses will necessarily be affected. We're talking about trying to go into community care. Charities are affected. Charities are closing down. This is a major issue, and I don't know how we're factoring that into our risk if we have taken that in. But every day we are hearing from businesses who are just saying it's just going to be too hard. We're just, we're not going to be working. And you'll have seen that in the charity sector as well. So will our colleagues from VFA. It's a big issue for us all, and especially when we're trying to move into that space. It's not going to be there as we'd expect. I don't know how we factor that in.
It's a good point about the strategic risk register, because I don't recall seeing it on there, but it might be that we've got that at operational level. So if somebody could take that away, maybe just to look at if there's anything more we should be doing to manage that, that'll be helpful. So let's go for a break then. We've got 10 minutes and we'll start back at 11:45. Thank you. integrated performance part of the agenda, which at the moment we're doing through the committee escalation. I'm going to hand to Patricia for the first one, which is the Assistant Executive Group Escalation Report. Patricia, over to you.
Sorry, it's fucking grapes up there. So I'm not going to labour on this for very long, predominantly because with the system executive group won't be in its existing format for very long because we're going to have a change on the 1st of April. So what this report gives you is just a flavour of the areas for discussion. There was one key decision that we made in relation to the item that you can see there around investment in the Wessex Health Partners arrangement. And what the plan going forward from April is that we slightly change the focus of SEG. So really pleased that Gillian has agreed to be the vice chair for that situation we've been in the past. And the focus of SEG going forward does need to be that we hold on to the operational performance framework. But actually, we've also got some significant transformation programs to deliver over the next few years. We need to have the system executive group really focused on making sure that we are driving those to the collective and making sure they deliver the benefit for the multi. And I think we've also still got some work to do on our system thinking and our collaborative relationships. And so I have sent out a proposal to colleagues to say that I think we need to shift the focus of the meeting, but also every other have some face-to-face development on system thinking and partnership working so that we're moving in the right direction and things don't commitment to each other. So I'm happy to take any questions.
Questions or comments? Okay, so let's move on then to the strategic outcomes committee. Okay, I'm going to go to you.
It was a very interesting meeting actually. The first big discussion was on healthy wage children and young people, and this was based on a report from the mobilisation event which was held in October in Bournemouth, which I attended as well, and I must say it was very good. I was going to say this isn't currently one of our funded priorities, but I was very glad to hear Patricia say that it was likely to be in the future. So that's really excellent. But the event itself provided an opportunity to gather information, discuss ideas and increase knowledge about what's happening, often with very little funding actually. It wasn't not heavy funding in this area, but it was interesting what was already happening. And I was just going to say this is a potential for future priorities, and early work will be helpful, but that's now out of date because it's a fast moving agenda at the minute at the ICB. We had updates on the Dorset Innovation Hub and the ICB digital programme, both of which showed how important it is to keep working on those and to keep working with the Innovation Hub, and I know there's a reference to that in the other reports as well. The update on the gateway process clarified for the committee not just how the process worked, but what it did and didn't do. And I think we hadn't been clear on that before. So it was really interesting for David to spend some time talking us through the whole process. It's clear that it's an important element in ensuring that there is a focus on outcomes, which is what the committee is about, and improving planning. The need for benefits risk management was discussed, and improved business case management has been identified, and training has been welcomed there. It's clear that if we get this right moving forward, it will make a significant difference in the way we work, but we're still in the early stages of that. But it was good to understand it better. We had a presentation on one of the 3 priorities, which was frailty and falls. This isn't developing as easily as the CVD and the respiration priorities for a number of key reasons, because it's a much more complex area and it's not just about clinical changes. But we welcome the work to date and the next steps planning, where subgroups are to be established and plans developed. Apart from that, actually, there was nothing on the risk register apart from what it says here, so there's nothing more to say about that. But yep, moving forward. Thank you.
Thank you very much. Questions and comments for Kay? just ask a quick one then? The falls kind of work that you're looking at, you say it's more difficult. We had a presentation to the board some time ago, didn't we, on the migration project? And we know that one of the things that came out from that pilot was that falls decreased, as well as other things. Is there an update on
defining what the key elements within it is yet?
Okay.
It's well behind the other two. And I'm looking for Paul here because he knows more about why that would be. But it was later in having the clinical lead actually appointed, and they haven't really got past. And it's an area that I think needs to move forward rapidly.
Yeah. Okay. I've got Paul and then Cecilia.
Well, I was going to come back on that. So one of the issues that we found in falls, unlike the others, is that and frailty is that there are lots of work streams going on within our system. There's some that we're aware of, some that we're not. And so the first phase that we're going through at the moment is really that stock take of what's going on and how we can, through this work, not take them over, but coordinate them and provide a link between them to make sure that there is synergy in driving towards the same sort of outcomes, and the hydration findings are feeding into that. So that was one of the pieces that was fed back there.
So it's not that project is no longer delivering the outcomes, but it's part of
the pilot happened. It's the what do we do with it now and how do we embed it is still part and parcel of that thinking. Yeah, absolutely.
Thank you very much, Cecilia.
It was just what he said, so that's fine.
Yes, sorry.
I think that when I think about the conversation we had at the beginning, around the challenges that Sam gave us, this is a really good example of where primary and secondary prevention really need to come together. Physical activity is such a massive part of it. Helping people of certain ages, we should be looking at muscle strength, not aerobic exercise. And I don't think we fully have grasped the fact that as women live longer, what the implications are for bone density, particularly if they're not able to take HRT, and we're not giving that broader advice on bone health that stops us getting into situations of really high rates of fracture neck and femur, which we have in Dorset. So we've got a lot of work to do to pull all those strands together.
And that's where they're at the minute. They haven't pulled them together. They're just beginning to form where are the key areas that we need to look at. It's not as straightforward as it was for respiratory, where it was about changing medication and things like that. It's much more complicated.
But the Dorset Innovation Hub team did go through this and picked it as their priority area as well. They absolutely recognised there was a number of those elements, and that Innovation Hub team is a wide-ranging membership, and they again coming back, this could be something that we could get into first.
My questions sparked lots of interest. Forbes, I'll bring you in a minute, but what I was going to say is, do you know what stage you will have done the review of what's going on in relation to falls? Because it seems to be an area that many people here are interested in. So perhaps if you can indicate a time when you could bring it back to the board, I think that would be helpful. Forbes.
I mean, that really was my question. You know, Dorset has struggled with the falls programme for a very, for the reasons that we're yet another review and yet another putting stands together. And, it's not absolutely not about blame at all. We've always got to this stage. And, Dorset a few years ago, there was an article that we were the falls centre of Britain, and proving the falls centre because we were spending so much money, quite honestly, and had so many fractured necks of femur that we're having to treat. And of course we know the demographic of our population, and it is something we
absolutely agree.
And there is absolutely a primary care and a secondary care role.
There's a discussion of timelines. I can't remember the exact details.
I couldn't tell you here, but if we take that as an
Let's
action.
get it agendaed
And
for the board.
okay, and through committee.
Yes, please.
Yes, we take it there.
Sam, you wanted to come in?
Yeah, just very quick practical question. Have you got a consultant in public health connected with the work?
Right. Don't ask me that secondary question because I don't know who.
No, that's fine. I was just offering a potential resource because we're going to have to review how we use our public health resource to do that advice to the NHS piece. So if it's a gap, let me know. If you're happy with the support that you're getting equally, that'd be good to know.
Brilliant. Thank you, Sam.
Okay, so Kay, we're going to stay with you for the prevention, equity and
Yep. And again, with prevention, there's a number of things that we talked about at committee which are coming forward today. So homelessness is one, oral health. It was a really interesting report from Health Watch that we had at homelessness, and we had a long discussion on it, Louise, didn't we? it highlighted areas where we need further work, and I think we need to be better in a number of these areas. So better engagement and communication, stress the views of the community were paramount, and there seemed to be a disconnect at that point between those views and the NHS's view of their own performance in this area, and that needed to be addressed. It's about culture as well as process. I think we decided, but it's moved on since then, and we've got a report later on today which has moved it on, and we'll be discussing it at that point. So I think probably I'll leave any other comments until then. The oral health programme update. We know how restricted we are in being able to make significant impact on the dental issues, particularly to do with access, because it's largely to do with contract and out of our control. But we welcomed the fact that in the discussion we had the ability as a local area to focus on local issues and do something significantly about them. And we were talking about, for example, the focus on children care, and also a number of other issues. This is a good example, we thought, of local planning addressing issues that we need, rather than just focusing all the time on the national dental contracts, and in particular the issue to do with training, which I know that the people committee have also been discussing in some depth. So although we know we're not making as much progress as we might hope in the area, we are focusing on what we see as our local priorities, and that, I think, is one of the big benefits of the ICB. I thought that was one of the things we should stress. The paper on GP collective action, well, Tricia has updated on that already, so there's not much more to say on that. We also had a report on inequalities, which touched on many of the key issues and the need to develop, for us as a committee, a better and more streamlined system of reporting, so we're clearer about progress towards objectives and what next steps should be. And that's something that I know is being discussed outside the meeting. We had a presentation about early cancer diagnosis in comparison with Hampshire and the Isle of Wight. And although it's clear that early cancer diagnosis across England is approved, there's still a considerable amount of work to be done in Dorset with things like prostate cancer and some others. So that highlighted some of those issues for us, and there was quite a long discussion about that. And the risk, again, nothing much to say on the risk register. So that was the key highlights.
Thank you. I won't ask a question, I'll go to others. Any questions or comments? Okay, Lisa then, for the People Engagement and Culture Committee.
Yeah, thanks. It's a long one this time. Dan, I promise I'm not going for the record on the longest escalation report that you set last time. I don't think I've hit it anyway, but I think we tried to we're playing around with this a little bit, try and make it more of an assurance report than a show and tell. And part of that is because we're still working on the IPR and the cover sheet on that to make sure that the assurance is given there. So we're joined up on that, but that's the reason why it's a bit longer. And also there are some chunky issues in here too. There are a few themes running through it. So workforce being one of them. And I think this is a reality check, really, because it's really clear that to the second bullet point, or third bullet point at the top, this is going to be a real challenge for all provider trusts to hit their workforce plans by the end of March. This is not a done deal. It's not in the bag. And so we heard about some actions that included tightening workforce controls and other things that are going to need to happen in order for those workforce plans to be achieved. And again, really important to keep our eyes on agency costs, which are okay, but also that doesn't just move cost over to headcount and whole-time equivalent. So there's a big juggling act to do here, and it is definitely not in the bag. So I think it's really important to eyeball that in this report. We talked also about in some areas there really is a need for more, and it kind of comes back to Patricia what you were saying about collaboration and strategic collaboration across the system, and it's really obvious in workforce that there's a need for a more strategic and mature strategic workforce planning approach across the system, and so the provider collaborative arena is going to be really important in driving that forward. And so we talked about that. We were reassured in terms of there are a range of tools, but I still think it's worth flagging that needs to improve. Dawn gave us I thought it was really helpful, a really good overview on the medium-term plan, and it set in context some of the issues that we were going to talk about and had already discussed in the committee. So the things that really came out of it, though, was that you can't tweak around the edges with this, and that major transformation programs are going to be really important. So we've already talked about the integrated neighbourhood teams. We've talked about electronic health record. They're massive dependencies to achieving some of the efficiencies around organisational design, workforce design, and all of that. And again, we come back to this is the theme: better collaboration across sectors, including the voluntary and community sector as well. Adult social care, all highlighted as part of that collaboration in terms of planning for workforce and resourcing. And I think that was reflected later as well, David, in your paper on financial recovery. I think that kind of links back to what you're saying as well. So loads of things to that we talk about here that you can see in today's papers as well. We did ask as a committee that in order to get under the skin of workforce planning, not just to get presentations and slide decks at the committee, but can we actually go and see it happening? Not to poke and interfere, but just to get a better understanding. So that was an action that went away that will explore opportunities for committee members to observe live strategic workforce planning as it happens, as well as getting the presentations back. We talked about the primary care training hub, and it became in my head a real primary care training hub, because we talked about it in relation to GPs, but also pharmacy, optometry, and dentistry as well. So we started to see how it can move across all of that scope and add value. But what we did ask is that there are some really important links to what's happening in the primary care training hub and mitigating some of the risks in the corporate risk register around workforce. So we wanted those links pulling out more, and we wanted more reference making in both the risk register but also the primary care training hub reports as well. We had a really good update from Raina, who's the group CEO of Agin Care, about workforce, and we ended up talking about resourcing and getting that perspective from a delivery partner was really helpful. And so she gave us a really good overview of both the strategic and operational context nationally and locally, but again struggling with recruitment and retention, and particularly for Raina and for social care, without international recruitment, it's proving difficult to maintain those. Quite a lot in that meeting. That's why it's a longer report, but hopefully we found it useful.
Thank you very much, Lisa. Cecilia?
I mean, it's obviously a lot of great work going on there. I mean, there are a lot of risks in relation to the primary care workforce that you pick up there in terms of the adequate number of trained staff and obviously difficulties there. But the key I want to pick up is the international recruitment. We have lots and lots of people in this county who are working age who are not working. You know, but how do we make a better connection between the opportunity? I know I'm not a wonderful question, and I know we're working on it, but it really does stand out. Why are we having to go overseas when we have people who could take these roles? And how does that link, if at all, to your training hubs and your training ideas? I don't know if there is a connection there. But giving people a better view of what happens in health and in social care, how those careers can progress, what more can we do?
I don't know if Lisa or Dawn, you want to respond to that now, or to take it away and think about it.
I'm happy to. Happy to respond. And Cecilia, absolutely yes, and that's why we have widening participation on our board assurance framework as because it's one of our key priorities. It's a risk, and it links back to Sam's earlier presentation and work through health. And
interesting yesterday was our people and culture steering group for the system, and there was a discussion paper that came to all of our partners about just that. And there is a lot of work going on in this space across the system, and pulling that together to make sure the benefits are being felt in the areas that need it most was the topic of conversation. So it's a really live issue, and that's just a snapshot of some of the stuff that's happening to work it through.
But it does, I mean, you know, again, external to the NHS healthcare, it feels like a really hard place to work. You know, we hear all the press all the time about how challenging things are, how difficult it is, how people are working all the hours. And I've got a choice as a young person, as to where to go, or even, you know, am I going to choose this? How do we change some of that rhetoric around it as well? Because I think the benefits and the joy of working in these spaces are not necessarily coming through.
Well, it's not, and we can create all the positive narrative we want, but obviously the media doesn't help. But I also think we're doing, Dawn's right, we're doing loads on widening participation, but we've also got to have a bit of a reality check in that some of the roles we're talking about don't pay very well. It also is a really expensive place to live, and regardless of the cost of living in this area, we're having some conversations yet again now about the national pay negotiation, because we took some bands out to the bottom of Agenda for Change because they weren't meeting the national living wage, and now we're having the same debate again, rather than getting ahead of that, which is where we were when we first implemented it, that people were maybe starting at the bottom of the scale, but they were starting well into the gradient of a living wage, and we're not there again now. So this all provides challenges when you're trying to recruit domestically, even for people who are not in work.
Exactly. So
if you're going to step in for employment and you can't even keep your head above water financially, if you work in public service, you're not going to do it.
So what more can we be doing to behind that?
I think the fact that this committee has people engagement and culture is precisely for that reason. I think that's why this committee was constructed in that way. I know Dawn and Lisa both want to come in. I've also got Matthew waiting though. So can I bring Matthew first, and then if you pick, because he might have stuff to respond to also.
So, thank you, Jenny. So it's really this issue about international recruitment. I'm very keen that as we have the conversation, we actually slightly reframe the point that has been made. So, firstly, like obviously from a provider point of view, we work really closely with colleagues who come here from overseas to work in Dorset and provide our vital services. And I think our starting point should be amazing appreciation for the work that they do, and to be working constantly with them to create a welcoming environment in which they are appreciated. And we also appreciate the difficulties that they face, both in terms of uprooting their lives, coming to a new environment, and for some of them, the difficulties of living in the UK, experiences of racism and that sort of thing. It's a really important aspect of this conversation. And so if we want to get into the issue of looking at our kind of Dorset working population and how to create opportunities in health and care, I think we need to make sure we're taking a strategic view. And that comes back to looking at our long-term plans and then what might make a difference, because quite frankly, where we're recruiting people from overseas, there are not people in Dorset who are available to come and do the roles. But there are things in our plans that would help to change that over time, including, for example, the development of a Dorset-based medical school, which was one of the issues discussed at the last committee meeting. So I'm just urging that we look at this strategically, but we also look at it through the lens of sort of culture and engagement and inclusion, in terms of welcoming our colleagues who come here from overseas.
So Dawn, then last comment from Lisa.
Thank you, Jenny, and notwithstanding Matthew's point, which I absolutely support. I wish my brain had worked quick enough on this one. I just wanted to bring the board an example of our widening participation and social adding social value in action. So through our emerging integrated neighbourhood teams work, what we're seeing is true integration of community health, conversations about what communities need. This is happening right now on Portland, and the opportunities that we have in health and care to provide for roles for these communities. That's work that's happening now. It was brought to life at the steering group yesterday, and useful for the board to know that those very conversations with our communities are happening right now.
Thank you. Lisa, anything more?
This always helps. It's the risk, coming at this from a risk perspective, that often helps me get this straight in my head, because you're right, Matthew. And when we talk about there's a need for a more mature strategic workforce planning approach across the system, this is exactly what we mean, because this is recruitment, and that integrated approach that Dawn's just described is exactly that. We also have to mitigate the short-term risk as well, though, to see if we can do some short-term recruitment and make sure that we have retention as well in the right places. So it is a mix of strategic for the longer term, but also we do have a risk that we have to mitigate now, which is a more tactical and a more operational issue. But I think I'm assured through this committee that both of those things are on the radar, and both of those things are being addressed, and there is a lot of work happening, and maybe some of that work can be brought to the board at some point with board assurance, as well as the example that Dawn just talked about now. I also want to remember, though, that we've got the staff survey coming up. Those results will be really key in terms of word of mouth and how our existing staff talk about their employer when they're out in their neighbourhoods and talking to their neighbours as well. So let's not forget the importance of the staff survey and what we do about that, rather than just looking at it as a bunch of stats and go, well, it was better than last year, so it's okay, because that's a big driver for something like this. Finally, one other thing I forgot on this report, because I didn't turn over and I should have oh no, sorry, it's not this report, it's the next one.
Okay, and just to clarify, the staff survey is the NHS staff survey, so we'll come back to that. Paul?
Just very briefly, I mean, the bottom line is we need more people who are able and willing to support and do care work. If we've got all this no criteria to reside, one of the reasons is we haven't got enough people to actually deliver that care in the community. But there is a reality check here, which Patricia's alluded to. Very briefly, where are we at now with the medical school? Because there was certainly a sense 12 months ago that we had actually a bit of momentum and pace to this, and it might actually become reality. And so I think every clinician I know would support having that endorsed in it for a whole host of reasons.
I mean, just from a committee perspective, this is the second time it's been to the committee. It's a long game. It's not a quick win.
It's a very long game, isn't it? Actually,
yeah, but it's positive. It's moving in the right direction. There is support for it, and it's the second time to committee, so it's looking positive from my perspective anyway. But Paul, do you want to give in more detail?
Yeah, so there is commitment from Bournemouth University and from our NHS partners that we proceed. Bournemouth University has got a strategic partner that they have to have as an established medical school. But there is a bidding and submission process nationally that they need to go through to be determined whether they are one of a number of next phase medical schools. And so currently going through the process of building up the case for that and going through that. So nothing's confirmed yet, but there is definite local appetite and preparedness to proceed.
So can I make a suggestion that, because I don't recall if that's actually been to the board before, the medical school former thing.
No, I don't remember if it has been to the board, but we probably, I'm not sure if we want it to come.
Quite early.
It's not information until
Not even the intention around it on what we might.
Oh, I think that came to the board.
You think that came to the board?
Yeah.
Okay.
Yeah.
All right. Well, I was going to suggest that came, but if that's already been done, that's fine.
To be honest,
I don't recall,
Jenny, once the bidding process has been through, the bigger issue for us to resolve is one, what's the actual purpose of it, which we've had lots of conversations on, because some of this is about providing a different type of medical education, and a huge bit of it is connected to the point that we made around widening participation. So location is going to be really important, and coupled with some ongoing conversations with the university about satellite nursing schools in order to widen participation. So it's a much broader conversation than just, are we going to have one or are we not?
Yeah, and it was exactly that reason. So just to be clear and to declare an interest, I do sit on the University of Southampton, which has a medical school. And so I think this is a much bigger discussion to make sure that we're not undermining the region as a whole.
Yeah.
So that's partly why I was asking about it. So at the appropriate time, I think, whenever you think it's appropriate, the board should have a discussion on that.
Yeah. So let's, if I have a conversation with the Vice Chancellor about the timing of that, and then I think we'll talk about whether there may well be commercial sensitivities around it, so it may well be moved into part two.
Yeah.
And if I get the timing from her as to when she thinks that's right, and then we can get it in the forward plan.
Yeah.
There's a risk if we bring it too early, two things will happen. We'll ask the wrong questions and we won't have the bigger conversation. There's a real sweet spot of a time to bring this, I think.
Dan, last one, and then we're going to move on.
I think it's covered. I was just going to support your point about let's put it on a future agenda at some point. Don't know when. We'll put it on why. Like, is it with a workforce lens? Is it with a why? Because otherwise it just becomes an update. But what lens are we looking at it through?
Yeah. Okay. So let's move on. Dan, you're going to do the Productivity and Performance Committee estimation.
Oh no, way to catch you up. I'm just conscious of time. Interestingly, we did the meeting virtually, and it was a different meeting because we did that, and so that just made me reflect about our mix of physical versus virtual, because we tend to go virtual we tend to go face to face for all committees. You have a different conversation if you're virtual. So just something for me to think about as chair. I'll pull out 4 things. Performance, we specifically talked a lot about the decline in category 2 waiting times for ambulances and no criteria to reside. And Dean talked to that before. We had an update on the winter plans. This was before Christmas, so kind of before stuff hit. We talked through the year-end financial position that's now been declared for the ICB, and then a bit of a forward look. In February, we're going to look at the 25-26 budget setting, lessons learned, and how we're going to approach that for the next financial year. So that's paper due in February. I'll stop there and see whether Dean or Rob want to add anything. I'll just take the paper as read.
Any questions or comments from Robin?
Just thinking about your point, kind of, we're considering the winter plan. It was December. It feels a very long time ago, and a lot has happened since then. I think on the performance front, it's worth mentioning that we've had the mid-year review process with the region as well during this time, which I think demonstrated the good operational performance that we've got across Dorset, but also gave us some things to work on. Just some brief headlines of updates from that. The 65-week position. At December, I was getting a bit nervous that we were behind plan. We are now ahead of plan for the end of January, on track to meet no patients, other than a few that are due to unavailability of implants or other things that they need, supplies, by the end of March. The ambulance response times for Dorset have recovered to the pre-Christmas levels that we'd expected, so under 30 minutes. I think the last 4 days we've been about 23 minutes for category 2 response times, and the handover times have been back to 30 minutes for Dorset. Not quite the same position for Swast and across the whole of the southwest, but there is it is starting to improve, but we are behind where we were last year. So the category 2 response times are worse for 23, 24, 25 compared to 23, 24. There's a process ongoing for that, and it's linked to mainly 4 hospitals where we've got across the southwest long handover times. The ERF, which will feed into the financial position, we are on track, if not ahead of our plan, our stretched plan that we agreed during our mid-year review process. And as I mentioned earlier, it's the no criteria to reside position that is that continues to be not where we want it to be or planned it to be, and we've got to recover that during January.
Thank you, Rob. Anything from you?
Just a quick point. In the integrated performance report, there's a month 7 finance report. It's October, and clearly we're in January now, so it's slightly out of date. David's about to do a financial recovery plan update, which was sort of the outcome as well from the BBC. Just to get ahead of that slightly, is that when David talks through the variants to plan that we've all agreed, we're on a monthly trajectory, month 8 and month 9 all the way through to month 12. So month 8 we hit our trajectory that was part of that declaration, and month 9 as well. We haven't closed month 9 fully yet, but the draft numbers are looking that we'll be on the month 9 trajectory as well.
Yeah. Okay. So we'll do more on the finances anyway when we get to the next agenda item. So, but before that, we've got the Quality, Experience and Safety Committee. And in the absence of Rhiannon, I think you're going to cover that, Lisa.
I am, and Pam, do jump in if I miss anything. Please, I'll bring you in anyway at the end. So important to say we discussed one incident and one never event at the committee, and that's about assurance, really, to make sure that the outcomes of the investigation come back to the committee, and they will. So just to close that one off. We also talked about maternity and neonatal. There was a quality update there, and it's going well. There is some positive progress. There's some service improvement. The challenge here, though, is not necessarily with the improvement of service. It's more about the ratings, because they're stuck, because the CQC can't come in and reassess. That we're stuck at a lower rating now than really the service deserves. And so what we asked in committee is, can we do some work around reassuring people in Dorset that actually the service is better than the legacy rating that we're now stuck with indefinitely, and we really don't have an end point when we can get that rating change for obvious reasons with the CQC. So that was something that we discussed, and assurance, and how are we going to get that reassurance in the absence of a review anytime soon on those ratings. We talked about SEND and how the ICB is meeting its SEND statutory duties in BCP. Again, there's some good progress there against plan. All actions are either completed or on track, so we got some good assurance there as well. And also the mental health review, and that was an update to the November board. So just for completeness, I'll mention an update on the intensive and assertive community mental health review work. And this is about pulling it into a single action plan with work requested by the CQC and other actions as well, so that it's streamlined and it's easier. So they're the key areas from there. It's also important, I think, to mention that we approved the addition of a new risk relating to the GP collective action, which we've already talked about, and noting and being assured that mitigations are in place for that in terms of quality, safety and patient experience. Pam, is there anything you want to add to that?
Just to probably build a little bit on that. So the maternity, we recognise for women in Dorset that obviously when they are looking to where they are going to birth, we publicly have 2 inadequate and RI ratings against our maternity services, and that does not speak to the tremendous improvements that have happened on both sites in terms of our maternity services. And we are using our maternity voices partners in this space to really reinforce that confidence for women as such. And I know, Siobhan, you're on that. You're using the terminology of weeks +2, etc., in terms of the move to the beach building, and I think are seeing an uptake actually in the number of women booking to birth now on the Bournemouth site.
It's 10 + 5, Pam.
Thank you. So I think what we're seeing is actually a positive shift in confidence around the services and stuff. So we are seeing the women booking as well. The SEND, just for colleagues, met with local authority partners yesterday, and Kathy, the DCS, and we are anticipating a BCP SEND inspection is likely to happen in Q1, and we're working very closely in that space around that in terms of preparation for the inspection as well. And I think quietly confident is dare I say it, as well. So they were just two things to share. And I think probably just worth adding as well that we were really grateful to Lisa and Rhiannon, our two of our non-executive directors, who shadowed our system quality group as well last week, and that was really helpful as well. Thank you.
Thank you very much. Any questions or comments for Lisa? So can we go to the final escalation report, which is the Risk and Audit Committee, Dan?
For the pleasure of walking in John Bezick's shoes. Again, I'll take the paper as read. There's three things that I kind of just pull out, I think, for board. There's a comment in there about the NHS-led replacement of the general ledger, and the finance function are, using technical term, all over that. And the committee's had a number of updates. The board is cited through this escalation report. The reason I mention it is when these things go wrong, they go wrong and really damage businesses, organisations. And so there is a risk there, but it's being managed at Risk and Audit and being Rob and his team. We talk about the internal audit update. There was a system operating model report, and it might be worth if board members who aren't on the committee want to look at that. It's something that we asked the Secretariat to send round because it's a good report and it's worth people seeing. And then we did our kind of an annual requirement for audit committees, looks at the effectiveness of external audit, internal audit, and the anti-crime service, and the conclusions in the paper. Again, I'll just pass to Rob, see if he wants to add or amplify. That was it, Chair.
Thank you very much. Questions or comments? Okay, can I move us on then to the Dorset NHS Financial Recovery Plan, and I'll go to you, David, for that.
Thank you. So I know we've kind of touched on this quite a few times in the discussion already. It's a really important situation that we're in at the moment in terms of our financial recovery. I'll take the paper as read, but there's a few comments to get us into thinking. So, colleagues, you'll be aware that we agreed a revised forecast outturn position at the extraordinary board meeting on the 28th of November. Since that meeting, we've had two in-depth discussions with South West NHS England to cover the details of the issues and the challenges that we're wrestling with, and to go through our plans to recover the revised position of the 25 million variance to plan. In effect, this gives us an overall deficit of 45 million at the year end. There's some accounting and technical adjustments for non-recurring adjustments this year. So the actual position will be minus 25, but because it's non-recurring coverage, it's actually will exit the year at minus 45. This report is intended to update the board on the discussions we've had with NHS England, the recovery plan's main elements, and introducing the H2 Recovery Delivery Group, which we've launched, which is effectively performance managing our recovery plans to the end of the year. And those items are outlined in 1.6 and in section 3. Clearly, these are challenging times for the NHS generally, as you will have seen through the national news reporting, and for us in Dorset as well. And it's vital for the good of our services and for the improvement of health and well-being of our population that we recover our financial position as quickly as possible. And therefore, the report is also highlighting the key elements of the work that we'll be using to get on the path to a sustainable recovery, as you'll see in section 5. And it talks about the work we're doing to increase our productivity, to reduce costs, and to transform services to get us back on track as quickly as possible. So this part of the report is really just to give the board an update since our previous discussion and the work that's ongoing to recover the plan. And as Rob has also mentioned, the month 8 and early indications for month 9 show that we're on trajectory to achieve that revised outturn position at the end of March. But this is just to give the board the insight into the work we're doing to get us there and keep us there. Happy to take any questions.
Thank you very much. So I'll go to Dan first and then Kay.
Thanks for a really helpful paper. You said it's kind of here to note and to provide some assurance about the grid, and the paper gives that, so thank you. There's every good papers, it then makes you think about what next, and so that my questions are kind of there. I am kind of slightly nervous for want of a better term, about the level of transformation work that's going on, led by, and I don't feel cited on that, but it feels like the work is concluding and having really positive impact. It's clearly really good work. I'm not sure the board's been taken along on that journey, and I just put that challenge back respectfully, that it'd be good to catch the board up on those key pieces of work and how they fit in to the strategy. It's referenced a bunch of times today. And then the other plea, and I suspect without speaking for you, you'd be on board with this, it makes me think about next year's budget. And we've talked a lot as a board. I mentioned in the PPC readout that we've taken a February paper on this to get ahead of budget planning before NHSE give out their timeline, so we do it for us. And so I'm really looking for, and PPC will pick this up, how we do the 25-26 budgeting early and not necessarily wait for NHSE timelines, and how we look back on the assumptions that crystallise, that cause some of the deficits this year, both in providers and at the ICB, and how we stress test those assumptions early as a board through 25-26 budget setting. And I suspect that's all in hand and you're thinking about that, but I think it'd be really good to engage the board earlier on that, formally or informally, so we don't kind of see another budget where we balance and then come the autumn we see the risk crystallise and we're off plan. So comments rather than questions, but thank you for the paper.
Okay. Can I just ask about the?
I will come back in.
Sorry, one phrase here. The historic increase of PHC spend is levelling out, and I wondered if we could have a little bit more detail on that, because the last report I saw on PHC, which went to your committee, Dan, suggested there were some green shoots there that suggested there was some savings coming, but this sounds much more optimistic than that. So I just wanted to inquire about that.
David, you want to?
Well, I wonder if Pam, because Pam leads the project in the PHC recovery, might have a comment on that.
And then will you come back to Dan's?
Yes.
Yeah, thank you. Pam?
Thank you, and thank you, Kay, for raising the question as well. I think it is fair to say there are green shoots, and there were more than green shoots actually over the course of the year. We had a mountain to climb at the beginning of the year, and Kay, you will be familiar in previous years that gap has been widening. We have been very focused in the area, and I think compared with previous years, and if we had been in a more normal year, we have made significant inroads in terms of maintaining a flat cash position in that space to the tune of roughly around £15 million. I think it's fair to say it has been hard. It has taken a lot of work. These shifts do not happen easily. And I think it's fair to say also that we still have a significantly long way to go in terms of the work that has to take place in there. It is an area of focus that I am daily involved in the discussions around and the actions and what we're doing around this space, but it is not a quick fix either. I think it's important to be honest in that space also.
So could I just clarify, Pam? Is what you're saying is that gap that we had is no longer increasing, or that you're actually starting to reduce that gap?
So what I was saying is that although demand is going up against CHC eligibility particularly, what we are not seeing is a corresponding increase in cost, in a nutshell, Kay. So we have delivered roughly £15 million of cost avoidance in that space so far.
More people, more demand, costs not going up, but also not going down in the direction that we'd want. Is that fair?
I'm going to appeal to Rob to help me in this space, because I think there are two different areas. There is the cost associated with CHC spend currently, and then there is the opportunities that are wider against CHC in terms of where there could be efficiencies and possible savings as well. And what we haven't seen is that moving at the pace we would want it to.
So we've been facing a 22% compound annual growth rate for the last 2-3 years. That's why it's been going like crazy. Where we've got to so far, and Pam is right, we have arrested that exponential growth. We are on track to be in what I'm going to term as real terms flat cash. So what a national expectation would be, we've brought it back to that. We've got a plan to get it back to absolute flat cash, which is actually less than real terms as well. So we can see the real terms, and we've got to find a way of getting down to the absolute, because that was the plan. The plan. So that's where we got to. So we've absolutely arrested the continue up. We've got it back to absolutely what you'd be expecting. But of course, the overall sort of iceberg underneath it is still a lot of money. We've got
So
to
the
bring it
gap
down.
has been, the gap is no longer increasing.
Not be going like that. The gap is the expected gap is coming down, but it's still got to keep coming down.
Right.
Yeah.
We need to be really explicit about it, which is what the subcommittee, the finance subcommittee, need to get on top of. Is we need to change the way that we commission for LD, and we've got to get learning disability communities, and we've got to get on top of that in 25, 26. That's where the next really big gain is. Moving to a population health approach with our local authority colleagues. And no matter how challenging that is to do it, we need to agree a framework for doing that and get on with that in 25, 26.
So Ben, can I just check, are you wanting to come in on this part of the discussion? No? Okay. So David, do you want
Yeah,
to?
so I just answer, Dan, I know you offered them as kind of comments. I think it's worth responding to give a bit of reassurance. So the work around there's a number of transformation programs, the two big ones around future care, which is the work around emergency and urgent care and integrated care. That has gone through some subcommittee conversations, in fact, cycle of meetings, so that hasn't come through the board for conclusion yet, but that's on its way.
On the agenda, there's a high level discussion about it with Newt and too.
So that
Sorry.
and there's a discussion with, and also around the integrated neighbourhood teams, which is our other programme, and that's on the next agenda as well. So there's the two things there. So just to give you that,
and really, if I can just, and again, it's for future. It's the scoping, risk management bit rather than the outcome of the work. And I just think the board seeing some of this stuff early would really help. The work that's been done is great, and the papers are great. It's just the scoping element rather than the outcome of the work element.
There's something about, I was writing it down this morning as we were talking. David's doing some work on updating the joint forward plan, but he's also leading on the MTP. And I think when you see the next version of the MTP before it goes off, yeah, there are the schedules that NHS England needs to see as a regulator, but actually we've tried to turn it into an integrated business plan. So there's a whole lot of narrative that describes all those strategic priorities, how they link together, what the sequencing needs to be and what we're expecting the outcomes to be. And then you'll start to get that feel then when that's been done.
Okay, so let's wait for that then. And
on the financial planning, quick comment, because I know we want to bring others in and timings. We're definitely working on that, trying to anticipate what the national announcements and allocations will be. But we are beholden to those allocations when they come, and they can significantly change our planning. But just to give you that reassurance, and we've got, in fact, system conversations tomorrow based on predictions and assumptions about that plan without actually having the final figures. So we are working constantly to try and get ahead.
And it's really difficult, Dan, to sort of make that prediction about what the budget's going to look like, because this year, 25-26 is going to be so different with the new government. There are a lot of planning flexibilities or hard stops that we're not clear on what the detail is. So we might set a draft budget and then find that we're millions away from it, which is why we're being a bit resistant to doing that. So we don't want to give the board or the committee a steer in the wrong direction.
Yeah, sorry, I'll be, because I agree with that, and anything we can do to support. I guess my point was more about the timeline and the envelope, because clearly you can scenario plan if we've got the timeline right. But thank you for the reassurance.
We're about to agree the planning schedule, draft timetable, the revised timetable, given that we're committed to get all this done by December. And now we don't have an envelope. That's been discussed and agreed with partners tomorrow. So there's no reason why at the next finance committee you can have sight of that.
Thank you.
Okay, Ben.
Thank you. It probably does follow on actually, because it's around sort of the transformation agenda and sort of budget setting. But I note in 5.4 the comment around INTs and the predicted 9.7 million saving for next year. And I think from where I see it, it's a big proponent of INTs and an excellent event yesterday. I know this on the agenda for part 2. That does seem very ambitious from where I sit in the community today to 9.7 million sort of saving within sort of 14 months. So just whether someone had a comment about that figure.
So I can move some more hands.
Yeah, or David, do you want to do that?
Yeah, so that's what's in the in the business case, and the business case was draft when I pulled those figures forward, and they're gross of any input costs that we need to put in as well. What I was trying to give the indication to the board of is the quantum of the opportunity that sits there, because if we've got a multi-million-pound deficit challenge in the system, what we need is schemes that could benefit the system to multi-millions of pounds over time. What we haven't got is the definitely signed off figures on that yet. And actually, I wrote this report between Christmas and New Year, and things have already changed between then and now anyway. But I still felt it was important to keep it in, because whether we can land those in the first year or the second year or the third year, there's still the opportunities that sit within that transformational change. And I think it's important the board has a sense of how that might emerge. So it's a good challenge. Thanks for raising it, but absolutely not a commitment at this point.
And Matthew, just briefly, because I know you're leading on this with Paul.
Yeah, so this, begins to take us into the territory, I think, away from this paper, which is how are we working well together to land the system this year in a very difficult financial construct. And I just want to support what David has presented here today. But picking up on Ben's point, and that figure will be explained in terms of the business case for the INTs as it goes forwards. And it's going to be really important that we're able to put some catalyst funding to get from A to B to achieve our ambitions. But I think one of the risks that we've got here is that because we have to focus so much on landing this year and putting together a plan for next year, is that we're drawn to the wrong places. And so when we come on, for example, to discuss our medium-term financial plan in part 2, I think looking at the financial strategy that we've got to support primary care, what growth looks like in primary care over the next 5 years, and how much money we can invest in primary care is a really important part of that conversation.
Okay, thank you very much, Matthew. I'm going to move us on, and we're going to move to the annual review of governance arrangements. And Liz, shall I come to you for that?
Yeah, lovely. Thank you. Thank you, everyone. We're coming today to ask for the board's approval on a number of changes to some of our governance documentation. The key one being the revised constitution. We undertake an annual review of the governance document every year, and that's the constitution and those documents contained in the governance fund. But like I think my deputy did a huge amount of work she's put into bringing these into this position today. This year we've also had a revised model constitution from NHS England, and these are the changes that we're bringing to the board for approval. I'll just outline those really quickly, and then I won't outline all the other changes until the documents, because it's in the paper. So the key changes we're looking for approval for in the constitution are removal of the references in relation to establishment, the addition of reference to the fit for the persons test, the addition of clauses about having a deputy chair in place for the ICB, which is actually something we already have in place. There'll be no change for us there. The introduction of a senior non-exec member, which we don't currently have in place, but we will be able to put that into place if we've agreed these terms. Changes to the chair's tenure, which will now be moving to 3 terms of 3 years, 6 years in total, possibly more with a rigorous review. And changes to the non-exec members' tenure of 3 terms of 3 years, with the possibility with a review after 6 years, and that's to bring that into line with the standard terms that foundation trusts use in their constitutions. There's also been some additional wording gone in around declarations of interest, which align with the guidance that we received earlier in the year, and that's been already written into our standards of business conduct policy. And all of those things were already mechanisms that we already had in place at the ICB, so there's no change there. We've also made one small local change, which was just that there wasn't consistency across the terms of office for all 3 of our types of partner member. We've just amended those to bring those in so that they're all consistent. So NHSE have reviewed those changes and they're content. If the board approves today, the constitution will go back to NHS England for their final approval, and from that date it will then go live and we'll publish it on our website and it will become our constitution. Underpinning the constitution, there were some other documents we'd like to also include. One of them was some small changes to the standards of the business conduct policy. That's been to our senior leadership team and also through our listening committee who are recommending it to board for approval. All the changes are in line with the guidance that we received from NHS England. And most of that has been around strengthening and clarification of wording. We've reviewed the policy and our practices, and I'm confident that we are implementing that policy as it should be. We've also made some small amendments to the scheme of reservation and delegation, which was for board approval. Key one of those is the addition of the Ambulance Partnership Board, and that's a delegation line of the delegation agreement, which the board have already approved. Two very small amendments to the Quality Committee and Productivity Committee terms of reference to add the Chief People Officer, ICB Chief People Officer, into both of those committees, and that's a recommendation that's come through our committees from the December meetings. And then we have minor changes to the SFIs, the nomination protocol, the function and decision map, removal of the placeholder for the place tours, and updates the list of primary medical services in the governance handbook, which are just for the board to note today that we're making those amends. So the key thing is to, if I could ask the board for approval of the changes to the Constitution, the standards of business conduct policy, scheme of reservation and delegation, and those two small amendments to the terms of reference.
Thank you very much, Liz. So this is our second item of approval today, most of which Liz has been actually covered in the paper. Thank you for the additional parts, particularly around the Constitution, Liz. So can I check if there are any questions or comments first?
Liz would love it if we had those email questions.
I'm happy with that.
Okay, so are we happy then to approve the changes to the ICS Constitution? Yes, thank you. The key governance documents, as Liz has just outlined, are we happy to approve those changes? Yep, thank you. And approve the addition of the ICB's Chief People Officer to the membership of the Productivity and Performance and Quality and Experience Committees, in line with good practice, as Liz has just outlined. People content to do that? Thank you very much. Those are duly approved. So then that takes us to the Homeless Health Plan.
Brilliant. I don't know, Anita was going to come back.
She was here earlier, wasn't she?
And join us. Big message.
Thank you.
So while we're waiting for Anita, if I just do a bit of scene setting. So towards the end of last autumn, really, wasn't it? In the end, that Health Watch. Thanks, Anita.
Thank you.
Health Watch did a review on homelessness healthcare in the Dorset area and published their findings. And we have seen that within our committee, but it was always our intention and our commitment to you for you to bring that to board. But more importantly, what is triggered for us, and Anita has led, and we've got the findings of it here, is a review of what is our approach as a system towards the provision of healthcare for this population, which has both its unique challenges but also its stark inequality in experience and outcomes. And so we pulled together not only what we are doing, but how do we respond to some of those issues that have been raised within the Health Watch report, and putting together what's then our plan going forward to make sure that within the resources and the relationships that we have, that we can best meet their needs. And I'm aware, and Gillian and I have been in email conversation earlier on today, that there is a degree of health focus in here, but there is also an understanding that actually we have to work hand in glove with our local authority colleagues in order to be most effective here, and that should then come to be a reality in some of the work that we do. So I'm going to hand over to Louise and Anita, who are then going to take us through the main key points of both the Health Watch report and our response to it.
Thank you. Who's going first? Louise?
I think I'm kicking off. I was just going to give you a brief introduction to some of the key messages from our report. Conscious that we carried this out last February time, actually. So it's been a year. Really what we wanted to do was, it was like a snapshot really of what was going on in the voluntary sector in the community at that time in a specific area in Bournemouth. So I'm aware that, there are lots of other organisations working on homeless health as well, food banks, faith groups, Paula will know of a multitude of other people doing similar work. But I hope that what our report brings across is
people's real voices, lived experience, and the lived experience of people supporting people who are experiencing homelessness in communities. So some of the key messages were around people still being refused access to GP services because they don't have a fixed address, digital exclusion, that's about cost and having kind of data on your phone, and the cost of phone calls. And, you know, I'm sure we've all sat on the phone at 8 in the morning trying to get through to a GP surgery and for 45 minutes, and you can't do that if you're, you know, conscious of how much that costs. Mobility issues were a real barrier, transport, and the cost of that. And then just about that kind of the way that life is if you're living rough on the streets. Life can be very chaotic, challenging. So being organised is very, very difficult. I think one of the key bits of learning for me was around that the lack of trust, actually, that a lot of people have in health services and in council services. And that felt like a really significant barrier. And then there were some specific kind of issues that people had raised with us around discharging themselves from hospital because they weren't getting pain relief support because they're having addictions. The limited availability of community settings for people to get bandage treatment for leg ulcers, which is a common concern if you're symptom rough. And then community mental health support for people. And of course, dentistry, which isn't even an issue, isn't it? A few more just on the next page, thank you. Just about kind of wider care needs, because that, I think another thing that really came across in all of this was people can't think about their health needs when they don't have anywhere to live and they don't have any food. So there's a primary kind of need that needs to be dealt with before you can consider your health. So that being very vulnerable to substance misuse, actually, if you're sleeping rough or if you've got really kind of temporary housing, and the difficulties of having temporary housing. Some people that we came across who were living in temporary housing for a long period of time, and the instability of that and how difficult it is to look after yourself in that environment. I hope that the rest of the report kind of speaks for itself, and that, you know, the interviews kind of, what we wanted to do was share people's stories so that you can hear their voices in all of this. And I guess the key learning for me is that it's like that mistrust is really significant, and the stigma that people feel when they've been kind of homeless, and the trust that they had in some of these community support services that they do not feel about the council or the NHS. So we really need to acknowledge that when we're thinking about designing services that will work for people. And then as well, I think that there's real opportunity here. The action plans give me a lot of hope. There are some small changes that I think could really make a significant, impact on people's lives. And I do think that integrated neighbourhood teams could be a big key mover in all of this. So I'm hopeful, and I'll let Anita kind of talk about, I know our recommendations from this report are all featured in the action plans. So I'll hand over. Thank you.
Thanks, Louise.
Thanks so much for that. Thank you, Chair. You'll notice in the report pack there's a report and the 53 slides in the slide deck. That's the overall report itself. I know you're disappointed to know that I'm not going to go through all those 53 slides. And given the richness in the Health Watch report, I thought what I'd do is just talk you through the content of this piece of work. It's really recognise it's the beginning of the intention to do a piece of focus work on homeless health. Really, we started off with just having a look and see what we are doing in the NHS system in the NCB around homeless health and what the opportunities for improvement. So this work has really, the Health Watch report was a source of rich insight to help us triangulate alongside the data that we have through our DICE system on the status of homeless health, on where people live, on that have conditions, on how they die and how long they live in poor conditions. And also to bring alongside that, not just the patient voice, but actually the evidence of what works and what good practice is. So we can look at it in the round. There's a starting piece of work to look at in the round what impacts on homeless health, what the opportunities, and where we should be as an ICB in a health system on that. So it's a baseline and stock take piece of work to draw out some opportunities for improvement. The report itself has a number of sections in which cover some of those things that I've mentioned. So we know that homeless people die sooner than others, live longer in poor health, they have less access to healthcare services, they present later, and when they do present and are admitted into hospital, they stay longer, significantly longer than other groups, and they have poorer mental health overall. So every single pathway homeless people are overrepresented tend to have poorer access, experience and outcomes. Louisa's talked us through that lived experience. It came through very strongly in the Health Watch report, and we also looked at some other sources of insight from some work that Red Cross has done in partnership with Dorset ICB on free to sensory leave, and some work that's been done really focusing on using homeless people research, but had some additional insight which we've used here through the I Am More Than project. And that told us about that lived experience of people, how they feel about using services and some of the barriers they experience. And that's some very simple things like registering with primary care. We know that everybody is entitled to register with primary care, that you don't need an address, that you don't need a number of things that people feel they need, but yet still people are telling us about problems with accessing primary care. We heard about access to primary and community care settings overall and barriers to access secondary care, for things that Louisa's highlighted, like the cost of travel, the fear of how you'll be perceived when you go to services, and access to some simple things like pain relief, particularly for drug and alcohol service users, and in that difficulty in access to drug and alcohol services in themselves, particularly when you have mental health problems. So a number of patterns are emerging that perhaps we were aware of some of these, but other things we perhaps thought have been solved, but people are still saying we have some challenges with them. So it's time to look again at those things. The report also pulls out some of the partnership work, and there's lots of this going on already. The assessment of the evidence base really pulls out the NDT model as a strength in how you support homeless people as part of a personalised care approach. Each local authority, of course, has their homelessness strategy, which we work with in partnership in the ICB. And so already improvement work underway, for example, in primary care, around access more generally, and for example, around how we improve dental services overall, including vulnerable and marginalised groups. The report pulls out some of that improvement work and also recognises that in addition to local authorities, services more widely and NHS services around health, wider partners such as voluntary council also have support services in place. Section 5 is the densest bit of the report, and so it's just pull out in detail some of that better practice guidance that alongside the Health Watch and wider voice recommendations, and pulls out a number of key themes and gaps and opportunities we can start to look at so we can see if we can make a difference to homeless health and really focus on the opportunities we have, particularly to take our work forward, not just on our own, but with our partners as well, starting to contribute to system plans in more detail. So you'll see that's quite a dense report. What I've done is summarise those things under 3 potential areas. There's some things that are quick wins that we can probably mobilise quite quickly. And those kind of things are around communication, but for staff and patients, around your homeless services we have in place, around access to primary care, and making information available in the way that meets the needs of homeless people on how they can access services, and to staff and our expectations of them when people seek to access services. We can put some new things that come along, such as low threshold services, where the evidence base says good practice is to have low threshold services, and things like pharmacy first, where people can get good response quite locally. There's some work to be done that's already started around drug and alcohol service commissioners and homeless leads coming together to unpick some of the problems around the pain relief and around access to drug and alcohol treatment services, people who are homeless. And some things around routine practice. We're reviewing our equality and health and equality impact assessment processes so that we can make sure we're systematically looking across all our services and policies for unequal impact, and we can embed the consideration of homelessness specifically in that. And those are all things that are fairly quick and relatively easy to implement. There are some medium-term things around further development and continuation of the NDT model, and around things like I've already touched upon the integrated neighbourhood team model and how we need to consider homeless people as that model develops. And then some longer term things, picking up homeless healthcare service commissioning as part of wider work on commissioning intentions. There's much more detail in the report on each of those things, but that summarises the short, medium and long term things that we could do and how we might take them forward. So my proposal to this group, bearing in mind this is a starting piece of work, really gives a stock take of where we are to build on, is that we formally put in place oversight of this development work through our Health and Qualities group. That's an existing group that looks at variation in access, experience and outcomes from services, and that reports up to PEOC. So that's the formal reporting route for this, and we look to bring back a paper to PEOC in 6 months to report on progress on this. And we continue to do two pieces of work within the ICB with the people that lead on all aspects of this work to bring our work together into a coherent piece of work within the ICB and to link in with those partnership opportunities led by our local authorities to work together on a strategic plan around how we do this in the round, knowing that we've got some more insight into where we are, the opportunities in the NHS to further build and contribute to that. And in doing that, both in the ICB work and as part of contribution to wider work, we develop our smart metrics, delivery timetable and so on, so we have some tangible, driven plan that we're holding ourselves to account for, and hopefully that people start to see some differences fairly quickly on and know the long-term ones are coming.
Okay, thank you. Just as a reminder, homelessness was one of the first things that we looked at as a board. So lost your mind back to that time. So I am grateful to Health Watch for the report that you did to kind of elucidate the issues. And of course to Anita and Paul for having it on the agenda today to bringing it here. We know it is one of the key health inequality areas for us as a system, so it's a really important place to focus. I know the report is here for noting, but it's in the context of what I just said, it's really quite important. We're gonna have about 15 minutes to comment, ask questions, etc. I have got a list of people already, so I'll say what the list is. If I've missed anybody, let me know. So I've got Kay first, then Gillian, then Sam, Matthew, Rachel. Did anybody else indicate that I haven't noticed? Okay, so Kay, if you go first.
Thank you for this, and I'm glad to see it coming to the board, Anita. We had a very good discussion on it at POC, as you know. There is a lot here which tells us exactly what the issues are. And I think my concerns about this report come down to two things. It's when we get to the planning, there are two things that worry me about it. One is the language being used, and the second is the pace at which this is going to be developed. So the plan is full of consider the barriers, review practice, things like that. But actually we know what the barriers are now, because the report from Health Watch and everybody else and all the voice we've got from people in Dorset have told us what the key issues are. So why do we need to keep reviewing them again? Because I think the issue here is about the pace at which we're moving on this. Because the longer you have to go out and talk to people all the time about what are the potential barriers and get probably the same answers back as we've already got, the less time we have actually to move forward and things. And I think pace is my second key thing. There's a lot in here about using the integrated neighbourhood team, and that's great. But the Integrated Neighbourhood Teams programme is rolling out with pilot systems in Portland and Boscombe, but it'll be a long time before it gets to the whole of Dorset. Meanwhile, what are the homeless doing? And there's some bits in here which I find strange, because you know the digital bit, it's get them free Wi-Fi, but we've already been told that a lot of them don't have phones, so that's not going to help. And also, I think there is a cultural aspect which is not coming out as clearly as it should, which is about the respect that should be shown to anyone who lives in Dorset, and which is, according to what we're hearing from the homeless in Dorset, not being shown to them. And I'm not seeing a really effective plan here to deal with that issue of making sure our staff treat the homeless with the respect they deserve. So I think there's some gaps there, and I think really at this stage, with the amount of information we've got from people like Health Watch and everywhere else, I think we should be at the point of actually putting actions in place and saying when they should be, when you want to see them happening, how are you going to measure that, what's going to happen to it, rather than continue to find out more. I'm not sure that we do need to find out more. I think we know enough now to be able to try and make a difference. It's going to be a long time before this plan makes a difference. So that would be my challenge to you, Anita. But I mean, I can see that you've picked out a lot of the key issues there, and I've picked out in the ones that, you know, some concerns I have for it. But that doesn't mean I don't recognise the amount of work that's gone into this. But I think it probably, I'd like to see it moving with more pace.
Is it all right if I capture quite a few of the comments, just so that we can get through most of them before we need to conclude? So, Gillian, I'm going to you now.
Yeah, thanks, Jenny. I mean, mine's a point about partnership and working with local authorities and wider partners as you would expect. And really welcome the Health Watch report, and really welcome this, and actually welcome its focus on health, because those are the issues that have been raised. And knowing that this was an issue in a report that was going to come to the board, I'd offered to the team that we would work collaboratively on it, which is what we did when the Health Watch report came to our scrutiny committee in December. And unfortunately, I think just because of time and a pressure of bringing the action plan forward, that wasn't taken up. And I think we've got a missed opportunity, which I'm disappointed about, to bring this to the board in a rounded way. And to bring some of the teams within the local authority and partners who have been working really deeply with homeless people and some of the issues that we have in the BCB place for many years, not just in the local authority but in partners as well. I mean, we, as the report acknowledges, are part of the Homewards coalition. We're one of 6 local authorities and places in the country who are working with the Royal Foundation on the challenges around homelessness, and we were chosen because of the strength of the partnership in the place. So to turn this into a positive, my plea is, come to the partnership and work with us to develop the health response in the context of the wider partnership responses there. This is a space where there are many partnerships and many tables. Come and sit round our table with us. Please don't set up a health-led table to solve the health-led problems. Come to our table and work with us to develop this further. I've got specific comments that the team have made for me that I could draw out about, the MDT approach is one that exists and is very positive. It's very focused on rough sleepers, which is a very particular population within homeless people in the BCP area. I'd like to see this be a plan that addresses homelessness in its broadest sense, including people who are at risk of homelessness, which is where a big part of our energy is focused. Because if we don't focus on prevention, we will never, ever address these issues. So I agree with the points about pace, but also I'm asking for something broader and deeper. But please come. There's a partnership there ready to work with you on it.
Lynn, can I thank you for being so productive in how you've put those comments, because I remember you making that offer to actually bring us here. So it is disappointing it hasn't been taken up. But thank you for the way that you've done that. I've got Sam, then Matthew, and then Rachel.
Thank you, Chair. I'll just keep my comments really brief. I'm really pleased to see this here, because I think sometimes my impression is we've brought this issue forwards and nothing's happened as a result. So the fact that we've got the makings of a work programme in train, I think is really positive. Just a couple of specific comments. I couldn't find any mention of health literacy training, but that's obviously a programme that's already up and running. I think that's really important for clinical teams. My biggest concern is about the scope. And is this about the NHS response to health provision? Because the space is quite fragmented. It's been fragmented for a long time. And I guess my 2 questions are, if it's about the NHS response and we're building more of an integrated approach in NDTs, remember the comment about trust and people not always feeling as if they're welcomed or as they're being judged. That's quite a lot to get past. So there's some careful thought about how to do that, working with people. I think the other issue is more, I don't know, Louise, whether you could comment on this. Is the sector more prepared to work together? Because sometimes I hear a little bit of what sounds like competition as to who's got the best approach. So it'd be great if organisations are willing to collaborate and to support NHS services to be as good as they can be, because there's a lot of organisations out there with some tremendous experience, and I think it's only by working together that we're going to get this moving in the right way, isn't it?
Matthew, then Rachel.
Thank you. So it's really great that we're discussing this issue as a board, and thank you for the work and the presentations. I think there's a good challenge here, really, in terms of sort of how we position ourselves as a board and what value we can add. And I agree with all the comments that have been made about the richness of the partnerships that are in place. And I think that we might want to do some more listening in terms of really understanding what's going on, and then how from an ICB, ICS point of view, what's the role we can take in filling some of the gaps with others. So I think the work that's going on in BCP is really important. I was really privileged to spend a day with the Dorset Healthcare Homelessness Service over the past year, and went out with members of the team and sort of was alongside them as they were doing some street triage, as they were working with people in temporary accommodation. And I just saw really how blended all the issues are. It's very difficult to separate out sort of mental health, physical health issues, housing issues, and ultimately people's journeys to employment or, you know, other aspects of their lives. What health can do is totally dependent on the partnerships with local authorities and the VCSE in this space. So I suppose, you know, my two things would be, one, for us as a board to think about kind of what we can do and just making sure we're properly informed as we're sort of intervening here. But also, Anita, to you, can I just ask, are we, in shaping the work, you talked about this being the beginning of a journey, are we involving people kind of directly from teams who are working in the area? So like Dorset Healthcare is only one piece of the jigsaw, but I'd be really keen that somebody from our team with daily lived experience of doing the work is involved in shaping our approach going forwards.
Thank you, Rachel.
Yeah, again, I'll be brief. Very welcome. I was in another conversation about homelessness recently, where I think it's about the quantitative data is really quite hard to evaluate impact. And I note that your draft success measures do largely focus around having plans in place. So I suppose a curious question in terms of whether there is a conversation about how will you know that the actions are working, both from a qualitative and a quantitative basis. And you may already, and like, let's talk about the dashboard, but have you got sufficient data to be able to evaluate, and how are you evaluating whether this work, and there's a lot in here, as you say, a lot will be tried and tested, is having an impact, and then modifying your strategy as you go along.
Cecilia.
Again, just points that were raised by both last contributors about sustaining the changes that you make in terms of how that is achieved through employment, education, housing, and other aspects of it, which I know were part of the work that the local authorities are working on. I think that's the pivotal piece. So it's great to be able to have a plan to help people get healthy, in order to change their opportunities, their trajectory, that long-term sustainability of anything. It has to be about supporting people to improve the way that they have access to opportunities.
So just before I go back to Anita and Paul to respond, then we saw a video fairly recently, didn't we, when we were at BCP Council, which I think is when Gillian made her offer to support. One of the things that came out from that was about listening. It was a really powerful thing about people feeling that they were being treated like a human and being listened to. So I wanted to kind of emphasise one of the points that Matthew made, actually, because I think it's really critical for this agenda. So lots of points there. Do you want to come in first, Paul, and I go to Anita or the other one?
Yeah. So I think so they're already helpful points, and there's lots of things there that we need to sort of talk through, and we need to then act on. I think the context here is that what we uncovered in this review is that a lot of those partnerships are already working really well. So health and care and voluntary sector professionals are really, you know, they are developed, they have those relationships and they work cross-sector really effectively within that care setting. And Matthew's been out, I've done the same, and I've seen that sort of effective working. And so part of the stock take says actually there's lots of really good stuff going on, but Health Watch have really helpfully shown us that there are some gaps, and those gaps are particularly leaving these patients at risk or struggling to access the things that they should have the right to access and should do within core NHS. So I guess part of the question and the challenge that I gave to Anita was, what are those gaps that the Health Watch thing has highlighted above and beyond the collaborative working that we've got in place, and therefore what's the so what that we need to do to try and close those. And I guess that's what we've tried to present. And I'm completely with you. There is no point doing this as NHS in isolation. So how we go about this will be in collaboration with partner NHS organisations, with the voluntary sector, with local authorities. And that's one of the reasons that we would want to hold the oversight of this within the Health Inequalities Group, because all of those system partners are there and part of that group, because to tackle those inequalities, whether it be homelessness or anywhere else, we need that wider approach rather than just the health focus. So I'm hoping, my intention is that because it's sitting there, we will have that attention to it when we're looking at are we delivering. And I think the last thing, Rachel, really good point. How will we know we're making a difference? And Anita and I have spoken about this. We've got the makings of a really good, with some really good starting points around a dashboard on our DICE, on our intelligence systems. So we've got a page on that, which gives us some really useful insights. Part of what we need to do is to look at those and see which ones of those do we need to have a significant shift on to demonstrate that we are serving our population better. And that will be part of some of the ongoing conversation that we need to work through.
Thank you, Paul. Anita, did you want to add anything to any of that?
I don't know if Patricia wants to comment first, and then I can. Or would you want me to just
say that again?
Sorry, I can add some bits now, or I don't know if Patricia had a hand up.
Gillian made, and whilst I understand why we want to keep a track of the health bits in the Health Inequalities Group, I still think there's some value in that, because homelessness is not predominantly a health issue, actually it's a whole range of issues. How do we embed ourselves within the partnership and use the Health Inequalities Group to keep track of whether we're dealing with the health issue? Because I think the partnership is what's important in delivering the whole. And a point that Lisa made earlier on when we were in the NEDS meeting, which is how are we engaging with the bigger charities that really have a lot of focus on this nationally, to learn, to get traction, to maybe also get some resource and funding to do some things. And Lisa mentioned the big issue in Dorset, and how are we engaging with them who understand this issue in far more detail than any of us could possibly hope to. I just want to put those couple of things in just for us to think about. I mean, and Paul and I can follow it up when we next have a chat.
So just because of time, what I'm going to ask, rather than you coming back and with more comments on that, I've taken a list of the comments that people have made anyway. Sounds like Paul has, and you probably have as well. So if you want those, happy to give them to you. But take that away. I think the biggest thing is, should we be leading on this, or should we be leading into others? And what I'm picking up is others are probably better placed to do that. So let's see how we contribute to that, rather than take out the specific health bit to deal with.
Can I just add to that? The intention wasn't to do just the health bit or the whole group itself, but to do both. So in order to understand where we were, so we can contribute to that group, but absolutely not instead of. So and I apologise, that wasn't clear in the paper, but it wasn't the intention to go away and do it, but to have somewhere to hold ourselves to account for our bits of it, because it's quite dispersed across the organisation. But absolutely take on board people's points. But that really wasn't the intention to do something completely separate. It was to have to hold ourselves to account for our bits, so we're keeping a tight grip on them.
Thank you. Okay, excellent. Well, thank you very much. You can see that again, there's commitment. This is really about outcomes and making changes for our communities, isn't it? And people are obviously engaged in that agenda and are supportive to you and others to get this right. So thank you very much for that. Okay, so we don't have any items for consent. We don't have any questions from the public. So I'm going to go to any other business first, see if there's any other business. I've got one, but if I start with Patricia, we go around. Gideon? No. Dan? Anybody on screen? No. I went up the other way. Louise? Okay. So I guess the only other business for me then was, as I indicated earlier, that Matt Prosser is going to be moving on. I'm assuming it's public.
Yes.
Yeah. I'm saying it in public or warning. Matt Prosser is moving on. He's going soon, which is why I assumed it was public. He is actually moving to Australia to work and live.
New Zealand.
To New Zealand, sorry, to work and live. So, and it's a shame we didn't get to say goodbye to him properly today because he's not here. But I did want us to record our thanks to him. I've got a particular thanks for when I came into Dorset. He was particularly welcome in enabling me to get across the Dorset system and understand, integrate with partners, particularly as when I started, we went straight into lockdown. So he was particularly helpful for me. Obviously, as the council, they're one of the key parties with BCP and the ICB in terms of what this agenda, what we're doing, and also the ICP, because we share between the three parties the working of the ICP. So I'm sure you will join me in wishing him all the best, and we'll wait and see what happens from here, won't we? So thank you very much for that. Date and time of the next meeting is on the 8th of March. What I'd like to do now is use the last 5 minutes, if we can, to review the meeting, and then we can allow the people that are joining us for lunch to come in. So any thoughts or comments on today's meeting, particularly anything that you think we need to learn from to take into future meetings? It's when everybody goes quiet and starts thinking about their tummy. But
I'd like to say that I thought Sam's opening presentation is extremely helpful. Not just because it's not just personally interested, but I think, as I said, the evidence is very strong. And actually, there's an evidence of return because last year we made a decision to invest in supporting hypertension management, and we're seeing a return in that investment. And that's, when everyone says, oh, it's the long term, Sam identified that actually there's quite short term gains that can be done as well in a segment of the population, and that will have a year-on-year benefit to the Dorset system, both in terms of health outcomes, but in terms of cost reduction.
I think these conversations tend to go to, well, we should have done this better or linked better. I thought it was a really good meeting. I thought it was balanced. It felt like a unitary board, and I'm sure we've had meetings before it's not felt like that. So just not to lose the positive, it felt good and balanced and strategic and covered a breadth of issues.
Thank you. Matthew.
Thank you. Really, just picking up on what Forbes said, I also thought the presentation at the beginning was really helpful, and I wonder whether there is a small reflection there about, for us as a board, the way in which we use data. So I think if you sort of triangulate our conversations, we need to be thinking about our kind of ambitions, our values, our strategy, and we need, I think on occasion we could sharpen up our use of data so that we're able to see the big issues across the system, our starting point, how we show up compared to others, and use that data to guide our discussion and our action a bit more.
Thank you, Matthew. Before I turn to Liz and Steph for key messages, I think one thing for me is, I think what worked really well today is that we started with a focus on our populations, with the population health management, and we ended with some real focus on parts of our population around the homelessness stuff. And for me, that's about keeping it real. So I think that worked really well. So if everybody did the agenda, thank you for that. I think that worked well. Key messages?
The latest our approval of the constitution and other related guidance. So that we welcome a deep dive. We're considering the opportunities on population health and where we should be looking at the focus. We looked at the challenges relating to winter pressures and the role in the winter plan in mitigating those. We reiterated the importance of our commitment to the work in frailty and falls. We used the quality, operational and performance aspect. We noted that final move to a 25 million variance to plan and the factors that will feed into the financial situation in the future. We really welcome that health watch report into homelessness and health. And I noted that we especially value the opportunity to hear the citizens' voice through that report. I think it's important to note that in response to the ICB's proposed action plan, it was agreed that this work, as it moved forward, it was vital that's in collaboration with partners, especially local authority and voluntary community sector, and that pace, culture and sustainability were going to be of key importance. And also noted our thanks to Matt Prosser for his work for the residents of Dorset.
Okay, anything else? Thank you very much. So we are going to break for lunch. We will start back at 2 o'clock. So we've got team members.